Good morning, participants. We trust that you had a good evening. We shall be starting the program at promptly at 5 past. We are having a slight technical challenge with the sound, so we shall be starting immediately at 5 past with the facilitator taking over. Thank you.
Good morning, colleagues. Morning, am I audible?
Yes, you are.
All right, thank you. We shall be starting now. May I request that we start with a prayer? Maybe request Reverend Sokana to open for us with a prayer, since we don't have the musical item. Reverend, are you there? Not. Mema Bue? Can you have a volunteer from the participants who may want to open with a prayer?
Thanks very much.
All right.
Thanks very much, Memo
All
Tsepe.
right.
We were muted.
All
So
right, all right.
Reverend Soka, continue. We were
I'm now
muted.
there.
Yes, thank you.
Please go ahead, Reverend.
Thank you very much, colleagues, and the chairperson. Greetings, all of us, in the name of our Lord and Savior Jesus Christ, and let us pray. Heavenly Father, we thank you for this opportunity that you have been given for us this morning. Come the Holy Spirit and lead us and guide us until the end of the session. Bless all the stakeholders that are gathered here today. Come the Holy Spirit and lead us to all suggestions and decisions might be taken to this meeting. We invite the Holy Spirit to guide us in Jesus' name. Amen.
Amen. Without a waste of time, we can start. Just yesterday, we had breakaway group discussions for the 8 groups, and we only managed to get feedback from group 1 and 2. So can we start with group 3 and move so that we don't waste time? Group 3, supply reduction and law enforcement. Can we have you?
Thank you, Memo Tsepe. Morning, everyone. So Precious is stuck in another commitment, so I'm going to be presenting on behalf of the group. Just waiting for my document to open. All right, can you all hear me?
Yes, we can.
Yes, we are able to. Thanks.
Yes, we can.
Yes, we can hear you.
All right, so we were discussing supply reduction related measures, effective law enforcement, responses to drug-related crime, and countering money laundering and promoting judicial cooperation. So I was the facilitator and Precious was the scribe. So in answering the questions, the first one was the goal of the NDMP relevant to your community or sector? Because it was supply reduction, was definitely a very relevant goal in dealing with and should remain in the NDMP, as was this is what came out of our discussion. The second question around what was missing, SAPs and relevant stakeholders must actively participate and be held accountable for effective monitoring of programs and policies. So this came out of a discussion on a training program that is done in partnership with civil society organizations. And there was a discussion around how does SAPs actually measure the impact of the program? So it's called the Dignity, Diversity and Policing Training, where it's a national program that SAPS does with the EPW department, so Employee Wellness Department, and they collaborate with civil society organizations. So 3 particular civil society organizations, Sisonke, which represents sex workers, Sanput, which represents people who use drugs, and then Triangle, who represent the LGBTI community. So the idea of the training is basically to train law enforcement officers on how to deal with these 3 vulnerable populations when they come in contact with them. So educating them on how to treat them with dignity and respect, and also educating them on what services are actually available, particularly for drug-related population. So the discussion around that was that in the goal, SAPS and other relevant stakeholders must actively participate and be accountable for the effective monitoring of programs and policies. So this is not only these training programs, but also any other policies. Another thing that was missing was that there's a need for policy reform due to a lack of harmonization in policies. So, for example, the Prevention of and Treatment for Substance Abuse Act lacks alignment with current realities. There is a shortage of rehabilitation centers, and harm reduction services are not authorized to provide care. So here, we had a discussion around how police officers do not necessarily have quotas when it comes to arrests, but vulnerable populations like people who use drugs and sex workers are easy targets. And so because the acts, for example, the law says that sex work or drug use is criminal, police officers will then be enforcing the law, and not necessarily because like the National Drug Master Plan says that people need to get services, but there's just this misalignment with the policies where the law says one thing and yet the policy allows for another. So there really is a need around policy harmonization, but also policy reform. What has worked? There's been great collaboration or cooperation when it comes to dismantling of labs and really addressing the supply chain of drugs. We've seen quite a lot of reports in the news about how police officers have, in partnership with other departments, the security cluster, have worked together to trace and follow this chain of supply and dismantling labs because of the coordination. So that's what has worked well around the coordination, but there is a need for enhanced operational coordination at all levels. So the discussion that came out of that was that police officers, for example, will do the heavy lifting, the work of finding and investigating all of these criminal networks or suppliers. But then when it gets to the courts do not have the capacity to convict these criminals or these networks. So there needs to be more coordination at all levels, either building capacity of the judicial system or finding ways that all the different departments work together in order to get an end result that is reflective of the work that SAPS does, for example. What blocked or delayed progress? There was a long discussion around the shortage of staff, so shortage of police officers. There is a need to get more police officers involved, the need to strengthen community policing forums. So there was also another discussion around the long turnaround time in raiding drug manufacturing labs. So it is a long process. It's not overnight. So long investigations, which has eventually led to long turnaround time, and evidence processing cannot be rushed. So obviously this is to ensure that cases hold up. So there's a need, we need to be mindful of the fact that these things take long, but it also does lead to delayed progress. And then the criminal justice system lacks the capacity to effectively handle drug-related crimes, leading to significant backlogs, resulting in suppliers being granted bail. And we see this all the time in the media, but also in our communities. So that is what has blocked or delayed progress. Lessons learned, to reduce the supply of illicit substances and address the shortage of police personnel, South Africa should aim to increase police recruitment by 50% annually. This expansion would not only create job opportunities, but also enhance law enforcement capacity, leading to improve supply reduction, overall crime prevention. That was, the main lesson that was learned. Future priorities, we had quite a few. So speedy forensic analysis will help to determine if substances are illegal. So the need for more forensic labs was a priority. So plans have been discussed. So General Matonsi mentioned that the minister mentioned that there would be plans to try and get at least one forensic lab in each province. This is obviously in the pipelines, so we can't say when it's going to happen, but it is a priority in order to be able to test for drugs and so forth. So there are plans being discussed to have one lab per province and to employ technology that will test for illegal substances in the field. So police officers to have the technology to be able to test drugs wherever they are and not necessarily having to transport substances to labs in order for them to get tested. There is still a need to harmonize laws to address the arrest issue. Example, quotas are not established for police to arrest people who use drugs as sex workers. Therefore, a consistent legal framework is needed to clearly define what is legal and illegal, which would guide police officers in making arrests. There was a discussion here, particularly around the cannabis judgment, where now police officers have to use their discretion when people are found with cannabis on them. So because the judgment says that it is not a crime anymore, police officers are able to, the arrest rates have not necessarily decreased significantly, but we are starting to see a change in policing. However, there was also Sanpur, a member from Sanpur shared we are still seeing people who use drugs getting arrested. So there really is a need for this harmonization of policies. So there's also a need for more stringent control over liquor licensed establishments, particularly taverns and bottle stores that are not compliant with regulations. In some areas, there are more than 6 taverns operating in close proximity to one another. Additionally, there are reports of premises selling illegal substances alongside alcohol. So this is, one of the big things that came up where we need to also start looking at putting more controls around liquor licensing and control of liquor establishments. And then another priority, our last priority, was to establish CPFs in every area. CPFs serve as a vital platform for collaboration between police and the community, fostering mutual trust and accountability. By facilitating open communication and joint problem solving, CPFs empower communities to actively participate in crime prevention strategies, leading to safer and more secure neighborhoods. So all in all, a very relevant goal, which should stay in the NDMP, but there is still need for prioritization to capacitate law enforcement to be able to effectively carry out their duties, and also harmonization of policies, which is quite key, especially in developing this. We need to prioritize being able to review policies that will hinder the implementation of the NDMP. Thank you.
Thank you, Memonaring. Colleagues, can we take questions? Rana, let's do maybe 2 or 3 questions or inputs to what Memonaring has been presenting on. Please let me know if the hand is up and I cannot see.
I see a question in the group, Memotsepe.
Yes.
So the question says, is there a designated specialized unit assigned with dealing with drug peddlers in all different law enforcement sectors?
Yes.
I don't want to answer because I might be misrepresenting, but if there's any law enforcement officers or representatives in the group, we can respond, or maybe members of the CDA can respond to that. But I do know that there are specialized units that, deal with the drug-related stuff. But yes, please.
Okay, do we have subs? I see Major Jen. Can you assist there?
Good morning, Chair, and to everyone in the platform. Yes, there is a unit. I was hoping somebody from Hawks also is here. There is a unit under the Hawks, but they focus more on serious drug cases, more organized drug labs and all those things. But there isn't a unit that deals with the, if I can use the phrase, all boys running around with drugs on the street. So they deal with more organized crime, more serious drug cases, and so on. But the unit is definitely is there. Thank you very much.
Thank you, Major Jen. I hope, Stanley, you are answered by the input from Major Jen. There's another question from Barent. How does the National Drug Master plan to address corruption within government structures, especially relating to SAPs? Charity, would you be able to answer that?
Oh, no. No, I wouldn't be able to, but it was a discussion that came up in our a topic that came up in our discussion around addressing corruption within SAPs, but I don't know how the NDMP plans to address this. I don't know if it is even within the jurisdiction of the NDMP to be able to address this. I think this is a more national coordinated response to it. But one of the things that did come up was really looking at addressing or looking at how the pay of the low scale pay of police officers has resulted in corrupt law enforcement officers. But yeah, over to the CDA to be able to maybe respond to that. But I don't think it is within the NDMP's mandate, so to speak, to address corruption, government corruption. So yeah, I think we need a more coordinated response to that.
Thank you. From our other colleagues, are you able to, or if there's anyone who is qualified enough to can answer that? Maybe from the department, if they're Hawks or any? None. Thank you. So we'll take Charity's comment that we don't have the capacity to can fully answer that one. There's another input from Zwake, or a question maybe. The suggestion is to ensure that LDEC actively participate in the community policing forum instead of saying there must be an establishment of CPF. That is the duty of partnership policing unit. In SAPS, I also suggest that there should be an intense monitoring and evaluation of this goal from City of Johannesburg LDEX. All right, thank you, Mzake, for the input. Since there are no other questions, I think we can now move to the next group, Group 4, access to medicine and prevention of diversion. Group 4, please go ahead. Do we have anyone from Group 4? None. Okay, maybe we'll come back to them. Group 5, are you ready? Governance and accountability.
Yes, we are ready, facilitator.
Thank you, ma'am. Please go ahead.
Good morning once more, colleagues. I am Isabel representing Group 5. And in terms of our group, the facilitator was Mr. Murabi, and we had 8 members. We were looking at Goal 5, that is governance and accountability. And then in terms of answering the questions, the first question that said, is the goal still relevant? Yes, we said the goal is still relevant, and we further suggested that the goal should be moved from being Goal 5 to be Goal 1, because governance, it is a foundation. And we also indicated that we should not leave anyone behind, because when you look at the stakeholders, in terms of the key population, the people who use drugs were not included, and also the issue of accountability and enforcement. We need to enforce and popularizing the act, and also the role clarification, and there should be a political will, and we need to have an oversight bodies for monitoring, and also the allocation of task. We made an example of the DTIC in terms of the amendment bill, where it talks about the issue of the liquor board, municipality, the police, and the community. And we further indicated that when you look at some of the task, the liquor traders are more informed than the community. And we also indicated that the drug-related legislation should be aligned. In answering question 2, what are the tangible aspects that we have seen happening? We indicated that reporting is done at a cabinet level, CDA, and a provincial level. And we have also indicated, and we've also seen that PSAPs have been established, and they are being appointed. Then there are local drug action committees established. However, we're still struggling, and there are roadshows on the establishment of the local drug action committees that are being conducted. And there have been public consultations. We do have a website. And then the issue of the oversight bodies also came again in this part. And we've also proposed that, yes, appointment is been done by mayors. It would be good if appointment can be done by an administrator. For example, if it's a municipality, the municipal manager to do that, because we know that in terms of the mayors, they change a time, and again, the mayor can be there for support, and this can also assist in terms of the allocation of budget. And there was a question that, yes, now we're reviewing the master plan, but which comes first? Is it the act or the plan? And that all the drug-related act should be aligned, and the issue of a strategy versus a plan. But we have agreed that we need also to look at the act first, then we can change the terminology. And then for question 3, what are the lessons that we have learned? Is that mayors did appoint some of the LTAC members, and the act needs to be reviewed, and the plan, and that the PSAPs to be changed so that we can use the correct term. Instead of PSAP, it should be PSUFs, that is the Provincial Substance Use Forum. And then also the involvement of the business sector. And we boldly said that things can be done. We managed to achieve a number of things in its structures. And then the issue of resources in terms of HR and finances. And also we indicated that the establishment of the office of the secretariat, and then looking forward, what are the changes and priorities to be included? It's that we need to bring the private sector on board. We should have adequate resources so that we can be able to implement, and then we need to escalate goal 5 to be goal 1 for foundation, and the urgent review of the legislation, and CDA being an independent body. And then what role should communities, the department, province participate on? We said in terms of the consultations, participate in the PSAPs, LTACs, and then we need to elevate issues of alcohol, because we see that alcohol is being glamorized, and hence we know the impact that it has. We used we name few example. We talked about IFAS, and then the issue of the cannabis legislation, and also we need to have toll-free numbers for the communities where they can engage, and also shifting the national liquor legislation to be. It was a suggestion that at least it needs to be shifted from DTIC, and also the representation of period in the structures. And then in terms of the future priorities, the National Drug Master Plan should talk on issues, and more information on alcohol should be emphasized, the role of provincial government and the liquor board, and also that things that needs to be done. We know that in terms of the recreation and sports opportunities need to be emphasized as an alternative to drugs, because currently the inequitable share of these facilities, and then LTAs needs to be visible and reaching out and contribute to communities. And there was even a suggestion that we should turn things around to say communities should be running taverns, not taverns running communities, and then they should be highly taxed. And I think that I've mentioned, and then the engagement of the liquor board and the IMC that we to be discussed during the need for the IMC structure. And there is a body where the MCs and MCs sits. Issues of governance needs to be stressed there. And the National Drug Master Plan should be summarized for communities, so that they will clearly understand, and there should be a clear distinctions in terms of the roles. An example was made that if there is something that needs to be led by CDA, let CDA lead. If there's something that needs to be led by DSD, let DSD lead. And lastly, the issue of policies and the issue of the age restriction, because it seems we're quiet in terms of that one. And I will let if group members, if there's something that I've left out, they can make input. Thank you, Chairperson.
Thank you, Sister Zenzile. Colleagues, may I request that you raise your hands if you need an input, or if you have an input or a question, because it's going to take us longer to read every comment on the side chat. So do we have group members? Do you have inputs or additions to what Mema Kusha has been saying? Or
Yes,
general participants?
Yes, ma'am, we have.
Yes, Aleta, thank you.
Yeah. Good morning, colleagues. All protocol observed. I think one of the issues that is missing in that was the issue that goal 5, as the governance, leadership, and accountable entry and accountable goal, should be escalated to be goal 1. The reasoning behind that was that if we are to have our structures and outline issues of leadership and have all our structures in place before we start to implement the National Drug Master Plan, we believe that we will have a solid foundation where people can start. Currently, goal 5, it's at the end. We start with harm prevention and supply. We go. At number 5, it's only then that we think of putting structures in place. We are of the opinion that once goal 1 becomes it becomes leadership, accountability, and governance issues, so that prior to us implementing, we ensure that structures are already in place to execute accordingly. Thank you, Chair.
Thank you, Mayor. Any other question? Reverend Sokana, followed by Marithas.
Thank you, ma'am.
Thank you very much, Chairperson. My input with regard to the actually my question is based on the the local drug action committee appointment. Really, I think the committee here, it was the right time really to discuss this matter, that since we're experiencing a problem with regard to appointing the local drug action committees in different municipality. Remember the section 60 talk about the mayor should appoint. Really, it was high time really to shift that responsibility to other portfolios in a municipality level, because since really we struggle to have a local drug action committee across the country the way it is expected. I think I'm fully agree and support the idea that it is high time maybe to think about how can we shift this responsibility from mayors to other portfolio committees or the managers of the municipalities, so that really we can have a smoothly an establishment, more establishment in our country with regard to a local drug action committee. That's really my input on that. Thank you, Chair.
Thank you. Marithas, Mr. Marithas, please. Mr. Marithas.
Thank you,
Okay.
Chairperson. Good morning, Chairperson, and everybody else. I hope you had a good night. In terms of this one, I just want to add two things. One is definitely on the LDACs, is that when they are choosing of members, that you actually have qualified people on the LDACs. That it's not just there for a popularity contest, but actually they know what they are doing. We have a lot of people that's been standing up over the years on drug education and working in the community that's not really seen light of day. And we should really have members on the LDACs that actually knows what's going on and understand the policies and the National Drug Master Plan. So that's the first point. The second one is something that I haven't heard much from is the faith-based organizations. When it comes to governance and accountability, the churches also need to be more involved with, for instance, the CPFs, the police, the LDACs, so they can also have an input in those areas. That's my 2 points, ma'am.
Thank you, sir. May I let that, is there a legacy hand or a new one?
It's a new hand, ma'am. I wanted to zoom into the issue of LDEX and the establishment of LDEX. Definitely, we did have that discussion. The discussion came about because when you look at the issue of municipalities, there are three categories of municipalities. We have metros, we have districts, and we have local municipalities. Those are the three categories. But when you visit the act, it says the mayor must appoint. We are of the opinion that the function should not be sitting at the political office. The function should be moved to the city manager's office, which is the administrative side, which is point number one. And the National Drug Master Plan or the Act, because there's a disjunction, like I had earlier said, because we are moving with the National Drug Master Plan every 5 years. But the Act has been promulgated since, we have been using the same Act since 2013, but having different versions of National Drug Master Plan. So the gaps that we have will remain. We also requested that the National Drug Master Plan one of the challenges was that people were feeling that we should have ward-based LDEX. They might work when you go to a district or when you go to a local. I even gave an example of the city of Joburg that it has 135 wards, but we had to have one LDEX as outlined by the Act. So when when the master plan looks at issues of governance, we need to zoom into SALGA and say, what can work best at metro level, what can work best at district level, what can work best at local level, because the formations have their own limitations. Thank you, Chair.
Thank you. Mtate Gama will be the last one. Moses Gama will be the last one. Then we have to move to the next.
Good
group.
morning,
Thank
Chair.
you.
Sorry, Chair. I think that's why Mama didn't report on this issue, me Aleta, because no, there was an issue how Gauteng tried to do the word base, and we know in terms of what happened. But we were saying if we cannot make no much impact at a regional one, then let's start there and make try to make some impact. And then as we make impact, then that's when we can be able, so that we don't stretch ourselves unnecessary. So it's something that can be looked at after making, because we all agree, as the chairperson Mayor Nandima Koza alluded, even yesterday, today, yes, we've made some strides, but not the way we want. Hence, most people, they still don't feel the impact of the National Drug Master Plan. Yeah, so I think Memzimela missed that point. Yeah, thank you so much, Chair.
Thank you, Ntate Gama. I hope the governance committee, the governance team, is taking note of the inputs. But what I pick up from all the speakers, there is a need for amendment of the law to ensure that the LDEX on the ground are safely secured in an permanent administrative position that will not be moved by political interference or changes like that. That's what I pick up. So governance, please, hopefully you took notes and relevant procedures can be taken. Now we'll have to go back to group 4. When we called them, they were not available, but I just saw now that group 4 is ready to present. Thank you. Group 4, please.
Thank you, Chair. Good morning, colleagues. I'll be presenting a report for Group 4. The facilitator's name was Dr. Guru. Okay, Group 4, we focused on the emerging trends and substances. And then on the achievement or progress, the points that we made was that the availability of methadone in pharmacies has helped reduce drug problems in communities. And the second point was that greater coordination of different government entities, such as South African Police Service, Department of Health, Department of Social Development, when conducting awareness campaign, has helped reduce the problem of substance abuse. Then we move to challenges. The challenges with regard to the implementation of Goal 4, the first one was difficulty in detecting new psychoactive substances. Colleagues, as you may be aware that the drug dealers, they always come up with a new drug almost every day. So it's very difficult for the agency, law agencies, to keep up with this or also to test these new drugs. Some of them, the law agency don't even know their name. The second point is the availability of methadone illegally on the ground because of the poor control. The third point was lack of access to services by users in rural areas. This is really a challenge. And then the fourth one was the training of police officers to test new substances, especially on roadblocks, because at the moment they can test for alcohol and other things, but I don't think they have the kits to test for drugs. The fifth point is the auditing of pharmacies to ensure that they comply with the regulations. This, I think, SAPRA and then the Department of Health need to look at, because we have spaza shops selling cough syrups, the same cough syrups the kids use to mix with Coke to make lean. So it's really a problem to check who's supposed to sell which medicine. The sixth point is there's gaps in non-scheduled drugs that allow medicines to be bought over the counter to be used to make new drugs. This is the point that I was referring to. And then point number 7 talks about the diversification of chemicals that make up NPS. Constantly changing drugs make it difficult to block them. And then the last point, also they need to have local presence, especially for authorities like SAPRA and South African Police Service. We move to the lesson learned. The first point is that there's a need for bigger labs with sophisticated testing machines. Testing should be centralized, simpler, and regular. And then the second point is portable labs with trained technicians to be able to detect new substances. The third point, regular assembly talks at schools to warn learners about the new drugs and also the dangers of substance abuse. The fourth point is using the media to educate kids about the new drugs and also alert the broader public. And then the fifth point is to benchmark with neighboring countries, especially those who have successful prevention programs, and try and apply them in our own country. And then the future priorities, the first point will be there's a need to improve technology. This will help with the testing, with speeding up and helping the police identify new drugs. And also legislation and policies needs to be in place to deter people from getting involved in making their own clandestine labs. And then the third point is the accessibility of information on substance abuse to the public. This talks about the establishment of national repository, which will have materials on substance abuse. And then the fourth point will be ensuring the functionality of local drug action committee and provincial substance abuse forum. This is an area where even in the last National Drug Master Plan, we struggle as CDA because most of the local drug action committee are not functional. I think this is due to funding and other issues. So if we want to see the issue of substance abuse go down, this is one of the future priorities that we need to focus on. Oh, no, I think that's it. I'll end it there. So maybe if I forgot something, my colleagues from Group 4 can help add to 1 or 2 points. Thank you.
Thank you, Mr. Mashika. From my side, it's the issue. I don't know if I missed it, but I haven't had anything on naloxone to save lives, because we know that there are situations where overdose is done and naloxone can assist in terms of situations like that. So that is just my input. Dr. Andrew, followed by CDA main host. Thank you.
Great, thanks. Yes, so very importantly around naloxone. So it should be moving towards the change of scheduling, so it doesn't require a script, and also to enable trained peer outreach workers and distribution in the community. Overdoses of opioids happen in the community, not in clinics. While there are other formulations like nasal sprays, they're very expensive, but the ampules are very cheap and affordable, and there are lots of good practices from other low middle income countries where they've distributed naloxone with great effectiveness. It's called the SOS program by UNODC and WHO, but also there should be access to naloxone for first responders like police and ambulance. Also, it would be great if there could be emphasis to support the fast tracking of other pharmacological interventions that are proven to be effective and enhance our management of substance use disorders, particularly in relation to different formulations, relating to long-acting depo-buprenorphine, various access to generic medications, and also medications that are required for pain, because that's also under international control. And if there's a mechanism to support cost reduction to enable affordability and local production, I think that's really critical, because otherwise we're not going to have access to the pharmacological treatments that many people with opioid dependence require. Thank you.
Thank you, Doctor. CDA main host.
Thank you very much. And I was in this group, so some of the matters that Andrew has just risen were commented on, and I trust that they are in the notes. But what I wanted to say was on number one, whether the goal was effective, it definitely was. I think Pete neglected to say that, and it needs to be kept in the National Drug Master Plan. But additionally, what we also discussed was that SAPRA currently seems just too high up and inaccessible, and to the point where people do not, at community level, do not even understand the mandate of SAPRA. So perhaps one of the things that we need to look at is how we can bring it down, perhaps have some officials of SAPRA operating at provincial as well as local level, so that they engage better even with SAPS in terms of the confiscation of illicit medicines. So that's something that I think if we can have as a suggestion or as a proposal or a priority, it would be helpful. Thank you very much.
Thank you. Dr. Guru, your hand was up at some point.
No, thank you, Chair. Actually, we were saying that Mr. Mashika was ready to speak. He wasn't able to raise his hand. However, I want to say he's covered the area very well, and I think we've covered much of the ground. And the key, I think, here is technology and monitoring at all levels. So I'm quite happy with that report. Thank you, Chair.
Thank you. Mr. Mauritius, your hand is up, and then we'll have to move to the next group.
Yes, Chair, thank you. Good morning. There's just one thing. I hear a lot of practices like methadone and things like this. And it really concerns me because methadone is a very strong medication, which was created in the Second World War to replace, I don't know if you know this, but anyway. So basically, it's a very heavy medication. So you're putting the user on something worse than what he was before. This is a very outdated method. The outcomes are very poor or low at best. And when I hear some of these suggestions, we've been talking about this for the last decade. And they are actually workable solutions that is a lot better and a lot safer than what's been mentioned on this group.
All right. Thank you. So there's no Jacolo. I see Jacolo.
I just quickly want to know that if there are options that are better and safer than methadone, can you just mention a couple? Because I know that methadone and opioid replacement therapy has got a lot of research behind it. So what are these alternatives in short?
I'll put a link down for you so you can have a look.
So you'll put a link on the comment site.
Yeah, I will
On
go
the
and find it.
Facebook.
I'll put it on there, ma'am.
All right, thank you.
You're welcome.
Can we now move? Thank you, Group 4, and the inputs there are from other participants. And yes, we need to. I agree with DC. There's a lot of people who doesn't even know what SAPRA is, what its role is, and the issue of accessing their services as well. So maybe there's a need for community engagement by SAPRA to make sure that communities are in a position to move and get services from them. Now we'll be looking at Room 6, community engagement. Community engagement and aftercare, are you ready? Do you have anyone from that? Okay, let's then move to Group 7, research development, monitoring and evaluation. Colleagues, can you hear me?
Yes, ma'am, we
Yes,
can.
ma'am.
Yes,
Thank you.
Chair. Yes, Chair, we
Okay.
hear you. Correct.
Both Group 6 community engagement, there's no one. Group 7, research, development, monitoring and evaluation. Is there
Good
anyone?
morning, ma'am.
Morning.
Good morning. It's Rajeshri Mudli. I'm reporting on behalf of Group 7 on research, development, monitoring and evaluation. Our facilitator was Prof. Mashabela. We had 4 members in the group and fortunate to have Nettie, who was from an emerging NPO and could give us relevant information of at a grassroots level. Just to say that in terms of the goals on the National Drug Master Plan, we did find them relevant, but we, emanating from the lessons learned, we have identified some gaps and where changes could be made. But for the purpose of this presentation, I will just run through some of the relevant areas. In terms of optimizing routine data collection, point 1, we said to identify and use existing data to inform practice and identify gaps in services. Sometimes they are data collected by the communities that we are often not aware of. The need is to strengthen the reliability of data collection from, for example, formalized sources. There are cases where treatment centers do not comply with the reporting to Sakendo, which impacts on the reliability of data. Hence, the need is to develop networks with data collection resources for support and insurance that such data is reliable. And then we've identified some of the gaps of the data, of data that we'd like to see collected. 3.1, this is point 3, sorry. At 3.1, we looked at public health facilities, render drug dependency services at 8 outpatient clinics, and such data need to be also included. Acute emergency data, for example, on drug-related overdose and mortality. In terms of monitoring and evaluation of National Drug Master Plan, we found that the need
is in the tracking linkages, monitoring of care and follow-up services across the sectors, to avoid people working in silos and to prevent fragmented services. Arising from the aforementioned, the following are some of the relevant points. There needs to be some kind of leverage between traditional indigenous grassroots practices and grassroots research in community with practitioner and academic research and services. Tracking should provide such data along a spectrum of care from screening, across the spectrum. I gave some examples that like screening, the waiting period, assessment, treatment, aftercare, and relapse. As such, one could then determine whether there are any gaps that need to be covered. Emanating from the monitoring and tracking, gaps in services, the service delivery must be identified and addressed. The aforesaid will set the platform for the emergence of best practices, which must be shared to strengthen services. Opportunities to alleviate unethical practices in promoting human rights that emerge must be used to develop an accountable and reliable system in reducing the harm, supply, and demand of drugs, as well as policy, alignment policy. An impact assessment plan is recommended, taking into cognizance the following, but this is not limited to the points that are being shared. One, the focus areas must be aligned to the National Drug Master Plan. Using the main indicators to each pillar of the NDMP for evaluation, the standardized procedures and tools for measuring impact must be user-friendly. A further deliberation to reach consensus on the timing for the impact assessment is necessary. Use of technology, example, digitalized packages to ease the task of impact assessment and monitoring. The necessary tools and resources must be accessible towards this end. In terms of to strengthen and guide research activities to maximize the impact and evidence, it is further recommended that the CDA draws from the research needs and develops a NDMP research agenda for the next 5 years. The identified priority areas that we found, but again, not limited to the mentioned, incorporate pharmacology as part of the research agenda. The next point, inclusion of drug testing, especially street drugs. The content, knowing the content of the drugs and alerting communities will minimize the risk of overdose. For example, if they could reduce the use of a particular street drug, knowing the risk factors and the high risk of overdose due to the content of the drug. Action research to develop strategies to reduce relapse prevention. Another point is on quality assurance to assure reasonable treatment with accountability required further deliberation. Also, when we look into the recommendations and the review of the National Drug Master Plan, as well as to strengthen and guide research activities, some of the suggestions were customer satisfaction surveys be conducted in both private and the public sector. Develop direct linkages with LDACs to understand their challenges and promote an acceptable standard of collaboration for integrated services. To conduct an annual door-to-door snapshot study in high-risk communities on service delivery, provide feedback followed up by progress reports. Monitoring of all registered services at a minimum annually to ensure compliance with norms and standards. Monitor and take action against unregistered facilities. Evidence-based accredited prevention programs are necessary to ensure that accurate information is disseminated and that quality of services is not compromised. The National Drug Master Plan be costed so that the resources such as finances are mobilized towards effective collaborative service delivery aligned to the district model. Capacity building, empowerment of communities to encourage ownership and self-reliance, reducing the dependency on institutionalization. Monitor prevention and treatment strategies and interventions in the community. This is linked to the point that it should not just be top down. We need to move bottom up as well to ensure that we meet the needs of people. Monitor prevention. Okay, sorry, I read that point already. The last point, development of an understanding of peer support, such as AA and NA, and understanding their impact in their community and extent of integration with formalized treatment. Thank you. That's the end from me. I'm sure our group will elaborate further. Thank you.
Thank you, Ma'am Rajeshri. Fellow group members, do you have anything to add? Inputs from other participants? Do we have anything? I see no hand, no questions, no comments for the research and development group. Okay, thank you. Then we shall be, I don't know, the group 7. Group 7. Maritas, please.
Morning, ma'am. Just one thing that I wanted to add. When it comes to the last group on research and development, there's one thing that I feel that's not been mentioned is the removal of the drug residues from the body. When somebody goes to a rehab, they tend to put them on medications and things that are supposed to help them get off. But what they don't deal with is the drug residues in the person's body that's dislodged, which is one of the main reasons why people relapse in a time period of 30 to 90 days. They should definitely research more data on that. And also, if they need research data, we can provide them with that.
So that is evidence-based as well method.
Yes, ma'am. There's actually many years of studies done on this, and it's actually being used in many different countries very successfully.
All right. Are you using it at your center or somewhere?
We use it at Narconon in Magaliesburg and around the World Health Centers in Narconon. If anybody is interested, maybe at some point we can organize a tour and explain how it works and have some of our professionals in that area talk about it. I think many of us that has been dealing with rehabilitation for many years would love to have something that works and really get a person off the drugs for good.
All right. Thank you, sir. If there are no questions for the research group or inputs, then we will check community engagement group 6. Are you still not available, or is there anyone from there? Panini Libise.
Yes, thank you, Madam Chair. Just one question for the research group.
Yes.
I would like to ask if they perhaps touched on the matter of the data that is produced by SAPS and other law enforcement with regards to people who are using drugs being incarcerated and then later being discharged without facing trial or such. Did they discuss the research on that data that is being presented? Thank you.
Thank you. Mayor Rajeshri, do you want to answer that?
Sure. It is an aspect, we did say look at all existing data and reliability, but we didn't look specifically into areas of data. I am noting this point so that our group leader will, when we present the final report, it will appear, ma'am.
All right.
Thank you. Chair.
Thank you. Mr. Mauritius, your hand is still up.
Sorry, ma'am. Let me take that down.
Oh, okay. Community engagement group 6. When you are ready, please mention on the chat box so that I can get back to you on that. Then we have group 8, financial resourcing and economic development. Please go ahead.
Thank you very much, Madam Chair. Sorry, let me just do something about my echo here. I do apologize for that. Honorable guest and esteemed colleagues, thank you very much for the opportunity to represent Room 8, Financial Resourcing and Economic Development, and that is in reference to Goal 7 of the National Drug Master Plan. If you would allow me to make an observation regarding the current meeting, there is a severe shortage of not only skilled persons, but a general lack of interest regarding financial matters. It is important to note that due to the current global political arena and the withdrawal of major funders, the sourcing of new opportunities to generate alternative income to government funding should be the responsibility of everyone involved. With regards to the previous budget, it was the general consensus of the group that the previous budget and the allocation thereof was not effective and was considered counterproductive. This was considered due to the fact that the budget for the National Drug Master Plan does not fall to a single entity, for example, the Central Drug Authority, but is rather seen as a branch of government. And due to this, it severely restricted the achieving of the goals and also the mandate of the NDMP in the previous financial cycle. Then again, not only from the people involved, but also from government and higher structures, there seems to be a reluctance when dealing with financial matters, and really a lack of appetite to allocate budget and adequate funding in order to achieve the goals of the National Drug Master Plan. The group further elaborated and stated that a coordinated structure or a platform that would have information readily available for organizations to access information regarding issues like how to be funded, as well as which programs and projects will be considered for funding. These aspects should be effectively communicated. Further avenue or structures to inform role players where and how to access funding, as well as structures to hold to account such players who receive budgets or funding as to how the money was spent and who were the beneficiaries thereof. Sorry for that. We further discussed and decided on motivation for the next cycle of the National Drug Master Plan should be evaluated. The budget should be evaluated, and also the goals should be evaluated in an entirety, and then be costed. To that point, what was indicated, the department's part of the Central Drug Authority, and that part be costed. Then that all government departments should incorporate the implementation of the National Drug Master Plan to be incorporated in their annual performance plans and their budgets. And then it should also be identified within their budgets with a clear description of their goals, the allocated budget for set goals, and a clear allocation in the broader budget. That is a quick summary. A reminder of issues that troubling the rural communities, who at times, especially with implementation and availability of funds, lose due to the fact that focus is often on urban areas at the expense of these rural communities that are also desperate in need of financing. Then a suggestion to add opportunities to monetize the industry, emphasizing a balance between patients and opportunities, and that such opportunities do not further harm the PWOD community members nor their families, whilst having opportunities that are specifically directed to benefit the PWOD communities. And then that also, again, with regards to the informal settlements and rural communities, that we have opportunities through monetizing industry that speak specific to the benefit of these communities. We drew on the recently or soon to be adopted legislation regarding the Cannabis Act, and how that industry will open up new markets and opportunities regarding substance use disorders and everything that goes hand in hand with it. In this case, relative to cannabis, and that the industry that is opened due to these new laws and then new industry be specifically for the PWOD community, to enrich them firstly, and then secondly also to prevent these opportunities from falling into the hands of major corporations, and then also foreign countries that we know would be a problem. Then there was sorry, let me just scroll down. We had a further discussion regarding the finalizing of the liquor bill, and we had a point that was raised to speaking to the minister not wanting to accept funding from the alcohol industry or the liquor industry, and that we should maybe bring forward the suggestion that those alternative sources of funding be reconsidered. Then a greater effort to include other sectors, including but not limited to the private sector, must be approached to further identify new funding opportunities, especially when implementation of the National Drug Master Plan is concerned, and that such funding is seriously lacking at this time. I thank you all for your time.
Thank you very much, Mr. Bukes. From my side, I would also like to emphasize the wide refusal of funding from the liquor industry when that can be used to amend the costs or effects of their industry in our communities. It's something else. I'm not sure if, and Tatemurabe can let us know if there's legislation on that, or if it's just something that we need to know, especially those who are doing programs with government. Tatemurabe, let me put you on a spot and say, is there any legislation that agrees or emphasizes that?
Good morning, colleagues. No, Member Mutsepe, what is happening is only the alcohol amendment bill that we're still awaiting. But the unfortunate part is that we're having a different legislation for different provinces. And this is where we are having challenges because each province can do as it pleases, as it deems fit for it to be able to succeed with whatever they want. But as to the general legislation, there's a concern regarding the national legislation and also the provincial legislation. It's not easy to change the provincial legislation if the national legislation is not up in place. Thank you, Chair.
Thank you, sir. Mr. Morris, your hand is up.
Hi, good morning. Good morning. Yeah, I wanted to just make a quick comment about this issue of funding by the liquor industry of this kind of sort of alcohol harm reduction or prevention work and treatment and so on. I'm not sure what the current minister's view on the matter is of DTIC, but certainly in the case of what happened in first of all, I should say that the global position from the World Health Organization, the Global Alcohol Policy Alliance, researchers around the world is that government should not take money from the industry unless it's through some kind of taxed process. So that if you set up some kind of a health fund and then tax from the liquor industry goes into that health fund, that's fine. But to take money directly from any industry player, for example, somebody mentioned yesterday that the liquor industry helps to fund roadblocks, set up roadblocks and so on. That kind of thing is totally discouraged because it sets up a conflict of interest for government, because government then, on the one hand, is having this partnership and accepting funds from the industry, but on the other hand, it needs to pass legislation which might not be seen as being in the interest of the industry, and the industry then turns on government and says, but how can you do this? Because we've been giving you money. So in 2010, there was a cabinet decision, 2nd of November 2010, there was a cabinet decision driven, I think, by Batabile Dlamini, who was then the Minister of Social Development. There was a decision taken that government should not, no spheres of government should take money from the liquor industry directly. Then in 2012, there was a letter circulated to all departments, national departments, by the Department of Social Development to say, please be reminded of this. But the reality is, as we know today, is that all spheres of government are taking money from the industry. They're taking money at local government level, provincial level, and national. And as people involved in the alcohol harm reduction space, we continue to see this as a problem because it helps the liquor industry to sugarcoat their image, to make them seem as though they care. But in fact, the reality is that they will only do things that are obvious to do, such as I say, for example, funding a roadblock, because everybody agrees people shouldn't drink and drive. But woe betide if you should try and ban advertising, they will immediately resist and complain and fight tooth and nail to stop that from happening. So then you wonder, how serious are they about contributing to alcohol harm reduction? So I'm just giving you that context because it's a very complex context and a very contested space, but it is the position of global activists in South Africa and in the world around the taking of funding from the liquor industry. Thanks.
Thank you very much for the insight into it. Yes, there's a lot of questions, and we know legislations may take very long to be impacted. We'll have DC Ntate Kama and Mr. Jakolo.
Thanks,
In that
ma'am.
order, please.
Can I just request that perhaps during lunch, we are going to have a video that plays, that speaks on big alcohol, which explains exactly how this works, as Mr. Smithers has just alluded. And also to just say, perhaps we can continue to write on the chat box areas or issues that, or messages that we want to put across so that we save on time. Thank you.
Thank you. Moses Gama, please.
Thank you, Ma'am Mutsepe. Yes, no, I was saying in terms of, that's where CDA and other stakeholders in terms of PCF and the LA to ensure that we push, the industry, because itself relocating itself, in terms of using that money for adverts and so forth. They don't necessarily have to give government, because already they are paying in terms of tax, but a certain percentage must be taken and be given to civil society organization in ensuring that they engage with community in ensuring that the harm that is caused by alcohol is minimized. Thank you.
Thank you.
I just want to add that the discussion on the alcohol industry is, there was nothing said that's incorrect, and it's a supremely complicated situation. The comment I just want to make is, when we're talking about ring-fenced funding or a health fund or something administrated by government, we are in the position that the list of priorities in terms of substance abuse and alcohol use, the list of priorities is so long that some priorities are just not met due to the lack of funding, even in this funding pool. To use an example, fetal alcohol spectrum disorder, which is our specific area of interest, is very low on the rung when people talk about preventing substance use. And if you're talking about funding interventions or funding support for individuals with FASD specifically, is then battered between social development, health, and no one knows who is going to be able to give funding. And unfortunately, that means that all of those individuals are missing out on resources. Thank you.
Thank you very much. In wrapping up, we're saying that I see a note. Thank you, Aaron, indicating that Suzette was the facilitator and the scribe, and she's not seen anywhere today. So it means for community engagement, we will have to move. We are already behind schedule. According to the amended agenda, now it's the time for Dr. Andrew to do the Mentimeter thing with us today. Dr. Andrew?
Great, thanks very much. So we can use Mentimeter again as we did last time. What we would like to get people's input on for now is in relation to the National Drug Master Plan, which is currently in operation. We want to know what we should prioritize to address. Just going to share. I need to be made a host, please, Nomthebo, so I can share my screen. We will use a similar link as last time. I'm also putting it into the chat. And then if you remember, there will be the presentation of a QR code that you can take a photo of. And this one is slightly different to the previous one. So what we've got here is this is the QR code that you can take an image of, and it will take you to this question. Or if you can't take it with your camera, you can put into your web browser, menti.com, and then you just insert this code, 89562493. What you will then see are the various current pillars, and on your phone, you'll be able to change their order. And what we're trying to do is prioritize where we need to place the most emphasis on strengthening the NDMP. So, for example, someone has moved now governance and accountability up to number 1, but that's only one person's vote ranking. So what you'll be able to do is each of the 7 pillars, you would be able to rank according to what area needs the most work. So if it's a pillar that's perfect, needs very little work, or maybe is less of a priority in our current context, you could rank that 7th. If people are having challenges getting onto Mentimeter, you can put it into the chat, and between myself, Charity, and Ms. Lamini, we will give guidance. I'll check my chat now to see if anyone is having any challenges. It seems now that people are getting the hang of it, but we only have 12 people on the moment, and I think we should have many more than that. Ms. Lamini or Ms. Monoreng, can you confirm that the correct screen is sharing, that people can see what's happening?
Yes, we can see the screen. We see it moving.
Okay, great. So we've got 95 participants, but so far only 18 people have accessed it.
Can you please explain again, Andrew, because maybe some people are not getting it?
So if people take their phone, if they have another device, and you put the phone over the QR code, this is this black and white checkered image. It should allow you, if you zoom in, to give you a URL code, which is like a www address. And you should click on that and it'll automatically take you to the slide. Some phones don't allow that to happen. So then in your web browser, if you use Google or anything else, you just type in menti.com. I'm putting that into the chat as well. And then once you get to menti.com, you will get a screen that asks you for the number. And the number that you should put in is also being placed in the chat now. If you're on your computer, you can also just click the link that is in the chat and it'll automatically open that up for you. You would just have to change between screens, depending on how your computer works so that you're able to see the Zoom screen. So for now, we've got 41 people's ranking. And you can see that there has been some change from how the order that the pillars are listed. So if we understand correctly, what people who have voted so far are saying is that the area where the most work is needed in the NDMP, so this is again, not in terms of implementation, this is in terms of the policy and how the policy is written and what's included in the policy. Currently, there's a mention that it's around prevention, early interventions, and education. Then, where the policy needs more strengthening, it's around treatment and harm reduction, followed by governance and accountability, then financing and resourcing. Again, just to reiterate, this is not asking about the implementation of the policy. We're currently writing and developing the policy. So, for example, there's been a lot of discussion around evidence and recommended processes. So if there is a terminology of evidence, that should be qualified. So, for example, there are global normative guidance on what is accepted as evidence-based interventions. What threshold should be in place if something is considered evidence-based? So, for example, evidence-based medicine requires that it goes through a grade process where the quality of the research, its generalizability is assessed along with values and preference research. And that is what gets then put forward by a global normative body like the World Health Organization, so that we qualify those sorts of things. That's it, at least around the interventions.
We have passed the 60 mark, Dr. Chevy.
Okay, I see there's someone with their hand up. Shall I? There is one other question that you asked me to include around separation of the pillars, or will we do that at the end of today?
Let's do that at the end. Please answer the question that is being asked. Ms. Mzimela.
Good morning. Yeah, I went through the app. It says, please wait for the presenter to change slides. I've been holding for over 10 minutes now. What does that mean? There's a cup, there's a little cup going up and down.
How did you how did you get there? Did you put in the code or did you take the photo?
I took the QR scan.
I think she has.
I used my phone, I took the QR scan, and then it says, it sent me to all the pillars, and I selected the pillar, a goal, and it has been saying, please wait for the presenter to change slides.
Yes, so you have already answered the question.
Okay.
So
all right.
Your answer is captured. It's now waiting for the next question, but we're not going to do another question now. So
well, I can exit. I can exit.
Or you can stay in the app because we will come back to it later. Yes.
Oh, all right. Thank you. Thank you.
So I will stop sharing then.
Thank you very much. Miss Rachel, are you still?
Yes, ma'am.
Please continue facilitating up until the break, ma'am.
Sorry, are we discontinuing with Mentimeter now?
Yes, we are done with Mentimeter.
Okay. According to the new agenda that was sent, we're looking at CDA presentation by Me Nomcebo Dlamini regarding key pillars for consideration. Can you go ahead with that? And thereafter we'll have a breakaway session, Sector.
Thank you very much. So on this one, we will just quickly run through the pillars for consideration. So what we are saying is we are needing to align the drafting of the NDMP 2025 to 2030 to ensure that we have coherence across policy and practice. And that alignment is with national as well as global frameworks. In terms of the introduction, we are saying here that as you all may be aware, a resolution was made, or a recommendation rather, at the last summit in 2023 that the National Drug Master Plan as it stands, 2019 to 2024, is a good strategy that just needs to be strengthened, and we need to ensure that it is implemented effectively. So what we are saying on this one, in terms of the alignment that we will present to the drafters of the plan, is that we need to strengthen alignment with the MTDP, which is the medium-term development plan 2024-29, the South Africa's National Development Plan, the UN's Sustainable Development Goals, as well as the African Union Plan of Action on Drug Control 2025 to 2030. So in terms of continuity, we, as I have indicated, have looked at the plan that we have currently 2019-2024, and we are saying on it, it needs to just be reinforced. Dr. Shibi just took us through a process where we were identifying the goals, and in all the engagements that we have had in the past 2 days, and also engagements that we have had prior to today, we have all been saying that we need to get implementation going. We need to get effective implementation rather than changing the plan. So the focus for 2025, we're saying it must be alignment and implementation, not reinvention. In terms of aligning with South Africa's MTDP 2024 to 29, the focus areas of the MTDP are building safe, resilient communities, strengthening social cohesion and reducing inequalities, improving public health systems and access to services. Those are the ones that we are focusing on. And those are the ones that we are aligned to as the National Drug Master Plan. And that alignment is around reducing the health, social, and economic harms that are linked to substance use. We need to ensure that there's integrated service delivery through and development of non-punitive we need a non-punitive lens. So we need to truly move away from the war on drugs and rather move to a space where we understand that persons who are affected by drug use need integrated service delivery. And that is what the National Drug Master Plan 2025 to 2030 needs to be focused on. We need to strengthen local drug action committees. I think that is just a given. And all of us in our different groups, even yesterday, we're talking about the strengthening of local drug action committees as well as multi-sector partnerships. Alignment with South Africa's National Development Plan 2030. On this one, the NDMP contributions are that it supports youth development, the current one that we are working on, which is not going to change much. It supports youth development, school safety, and healthy communities. It reinforces community involvement in substance abuse prevention, and it builds institutional capacity for social protection systems. And in terms of the NDMP 2030, it envisions a healthier, more productive population, reduced crime, violence, and substance abuse, and it envisions strengthened community institutions. On the SDGs, The relevant ones that we are mentioning here are good health and well-being, which is goal number 3, and target 3.5. Goal number 10, which is reduced inequalities. Goal 16, peace, justice, and strong institutions. And the NDMP contribution towards this is it supports universal access to prevention, treatment, and rehabilitation. It promotes equality in service provision for vulnerable groups. We mentioned the people use drugs, as well as LGBTQI plus communities and other communities that are vulnerable. It strengthens governance systems and community participation. So that is going to be, we are continuing to say that that alignment needs to be there. Aligning with the African Union Plan of Action on Drug Control 2025-30, the AU objectives are that we promote health-based responses to drug use, enhance regional cooperation on law enforcement, and that one is quite critical, strengthen prevention and treatment services, prioritize harm reduction and human rights. And that prioritization has been indicated, and even in terms of our discussions in the past yesterday and today, we continue to be focused on this. The NDMP contributions to this are the advancing of public health-centered, rights-based policies, promoting cross-border data sharing and collaboration. We need to continue supporting African regional drug control priorities through national action. And those are the 4 that we are presenting to the drafters of the National Drug Master Plan. And then what we are also presenting as key takeaways on this one is the deepening of alignment with domestic and global policy. We need to ensure that the National Drug Master Plan 2025-30 is aligned and we don't see ourselves moving in a different direction to what even the country has signed on as like the conventions, the 3 international conventions and all other policies that are in existence. We need to make sure that the NDMP 25-30 is aligned. We need to promote lasting social, health, and economic impact. We need to maintain continuity in goals while improving delivery and accountability. What must be considered, even as we are getting into the next session of the breakaways, is which alignment areas are most important for the sectors that we're going to have these breakaway groups. I believe there's 6 of them. So as we are discussing in the group, we also need looking at the policies that already exist. Which ones are we seeing as aligning with your particular sector in that particular group that you are going to be in? And how can sectoral roles be refined to maximize on this policy alignment? And that would be it. And this is not necessarily expecting a discussion, except if that discussion is, where am I? Except if the discussion, Mayor Mtsipe, is around beefing up what other policies may be there that we need to consider. Thank you very much.
Thank you, DC. Can I get a guidance from you on how to move forward now?
We are moving forward to, and perhaps because we have lost a lot of time, may we ask that if there's any additional policies that we have not listed here, that participants would like us to consider as well as a submission to the drafters, please just list those in the group chat. And we are going to move straight into the break. I believe that that's the time for the break now, if I'm not mistaken, Ms. Mtsipe.
DC?
Yes, ma'am.
Yes, I'm just checking because I see we are behind schedule. How long should the break be? And then when we return, we're going for breakaway sessions where Reverend Sokana will continue.
Because we are behind time, ma'am, may we just go, because the agenda now says 10:45 to 11. We are going to allocate the rooms. So the rooms are going to be the 6 breakaway rooms. Yesterday, we had them listed in names. So today, what we are going to do is immediately go to the breakaway rooms And may we ask that we go straight to the rooms as per the agenda.
Okay.
The
So we
6
will have people
open.
assisting
Okay, we
with
are going to,
allocating rooms to
we
people.
are going to share the agenda just now, ma'am, sorry, so that we can see the rooms as they appear. There's 6 of them. Charity did not do her work today. Charity, where are you?
Hi, DC, I didn't hear you.
No, I'm saying you did not do the work of allocating rooms. So now,
Oh, now you're dependent.
when you are not around, I struggle. But people are getting
I'm
into
sorry, but is it working? Okay, great, it's working.
Please pick a room that you would like to go to and take yourself to that room.
Colleagues, I was invited to room 1. I went into room 1, which says here National and Provincial Government Departments. When I went into room 1, it said it was for women-based organizations. So I came out. I want to go into room 2, but it won't let me because it says I've been assigned to breakout room 1.
Oh, that's weird.
Sorry, Chair. I think there's a problem because I want to go to room 6 and it keep on taking me to room 1. I don't know what should happen in this case.
Nomcebo, you might have to close them all, reopen them, and just change the functionality for people to select the rooms, as long as the room have been named accordingly. I can assist if you give me co-host.
Yeah, let me give you co-host
Okay.
so that you can assist with that. Oh gosh, where's this thing? Okay, I've made you co-host, Andrew. Thank you.
So I think we might just have to make it
Start
another.
afresh.
How many rooms do we want? 6.
Yeah.
We might just have to make it another session. I'll just do it quickly. And people can choose their own, is that right?
Yes.
May I request that maybe whilst we are arranging here, could be given that 10 minutes or so break, and then short break, and then when we resume in 10 minutes, then we are all cylinders going.
Yes, fully support. Seconded.
I'm not hearing a response from the main host and the support host.
No, it's fine, ma'am. We're trying the tech this side.
No problem. That's why we were saying let it be
we're
just
going to
that
write
minute
message,
break,
it's
and then at 11 we are all cylinders going, or just 5 minutes and all cylinders going. And also when we click on join breakaway room, it just takes us, I think, all to room 1. So maybe that should be readjusted. Thank you.
Yes, we will address all that now. I'm sorting it out.
Thank you. Dr.
Andrew, I've closed all the rooms so that we can set them up again.
Yeah, it's not allowing me to set up your upcoming session planned. Now not allowing me to access that.
Okay, let me rather make you host, and maybe that will be better. Because
Yeah, everyone was allocated to room 1.
yeah, I see that now.
It's now not allowing me to change.
Is it allowed now?
No, I don't know if can't we just close the rooms now?
All the rooms have been closed. Oh. A message was pasted on the group, in the rooms.
Sorry, DC.
Now we are back.
Yeah, we're trying to solve the problem. So we have asked that we take a break until 11:10.
Okay.
Because like there's a glitch that we are trying to solve.
Thank you, DC.
All right, thank you. So we are on break until
Break
10
until
past
11:10. Yeah.
Thank you. That's it, colleagues.
Okay. No, thank you so much.
Can you explain it again, Memutsipe?
Thank you.
Memutsipe?
Yes, Megela.
Can you explain it? I missed the explanation.
They're trying to sort out the technical glitch. So there's a comfort break until 10 past 11.
Okay. Okay, thank you.
All rooms have now been opened. Please go to the room that you have chosen. Kindly note that we have 50 minutes in this session, and we request that we keep to the time. Thank you.
So the same thing has happened. It's given everyone to one room.
Yeah, yeah, that's right. I'm being invited to join room 1.
Incredible.
Do you still have the main host?
No, I'm co-host. Let me see.
Or other room that's appearing here? Okay, let's.
If I launch the next session, let's see if it'll allow me. People should
be taken out.
They've got 60 seconds, and then the next session should come up. We'll see if that works out.
Okay. But I can see the other rooms are there.
Yeah, but people can't move to those ones because they've all been allocated to room 1. We have to do it manually.
Mm.
But I've tried to launch the next session, and we'll see if that works.
Okay.
In 30 seconds.
DC. Dr. Andrew. Okay.
Hi, we can join the rooms now. They're coming up on the screen, but can you remind us of what the actual rooms are, please? 1 to 6.
Yes, room 1 is government. Room 2 is civil society. Yeah, in the chat, I'll put the various rooms. Now that they've started, I'm not able to change their names. So
Thanks.
I will.
Just for clarity, if it says government, does that mean everybody who works for government should join the government one, and people who in civil society should join civil society? Is that how it works?
Yes,
Okay.
aligning with people from your sector.
Thanks.
I'm sorry, I'll give you the names of the other groups in a moment. I'm just pulling up them. Okay, so 3 is research institutions and academic institutions, 4 law enforcement and regulatory bodies, 5 is youth, and 6 people who use drugs. I'll also put it in the chat. So the intention, Panini, of the groups is for people who come from the same sector to have an opportunity to discuss things together. So from yourself, Panini, it would be to join group 6 in room 6, which is the people who use drugs. The allocation is a proposal so that you're with other people in organizations that have similar priorities or mandates. For clarification, while many of the law enforcement agencies are part of government, there's just been a proposal that in a way is a separate sector. So in a way, I suppose it's the justice cluster of government, and then the health and human development clusters of government is group 1. You should be offered to access a room. I see people are asking that. It should come up onto your screen.
Thank you, Doctor.
If there are people who are still struggling, who are still in the main room, you can put it in the chat and I'll allocate you.
Is it possible for me to go to room 1, please?
You put it in the chat, please. If it's not allowing you to self-select, then I can see who it is. Thanks. And I'll
Thank
allocate
you.
you. But otherwise, you should be able to self-select. But if you put it in the chat, then I can see who the person is, and then I can allocate you accordingly. In this main plenary, if there's anyone that's from law enforcement or security and you're waiting to be allocated, please let me know. There's been a request from that breakout group for people to join. You either raise your hand or put it in the chat and they'll allocate you, or you can just self-select room 4.
Dr. Andrew, I don't know, as the main facilitator, should I go to any of the group?
Yeah, I think, Reverend, if you work with civil society and faith-based organizations, then room 2, I can allocate you if you like.
Okay, thank you.
I'll allocate you,
Yeah.
sure.
All right.
It should give you an option to accept, Reverend Sokana. Whoever's joined, you're welcome to select one of the breakout rooms and join them. The option should be there for you to join. If not, you can let me know what room you'd like to be assigned. If you scroll up in the chat, you'll see what the room allocations are.
Excuse me, Doc. I just wanted to find out what time is the session starting? Dr. Andrew, are you there?
Andrew, Dr. Shebe, is he here?
I'm here.
What happened? You closed the rooms and then we refused to come out.
I didn't close them. They may have happened automatically because it was on the 30-minute break. Do you want to reallocate them or
No,
close them?
we need to close them. We have taken more than an hour actually.
Okay.
Yeah, so we need to close the rooms so that we can come back, but maybe give people what? How long does it take? But we need to close them. Thank you.
I'm sending a message now that we'll close them at 30. It's 60 seconds. Well, I can give them more time.
Okay. Yeah, maybe give them 5 more minutes. Let's close them at 20 past.
Okay.
Yeah, thank you.
Cool. Yes, I'm here.
Angie is someone from Vodacom, meaning the parcel has been returned to Vodacom, and then now you need to start the process by upgrading again. But
I trust we are all back now.
Good.
I'm seeing that there's 82 people in the room
Yeah.
again. We are supposed to have a break so that I'm trusting that the facilitators and scribes were able to consolidate. May I ask that Reverend Sokana, you will take over after the lunch break because we have sort of messed around with your time and we apologize for that. And we shall at this point take that short break between now and 12:30. And then Reverend Sokana will come and facilitate the next session from 12:30. Thank you very much.
Thank you.
Thank you, DC. Are you taking us back to the the breakaway rooms, or are we good? We are just on break?
We are just on break. The assumption
you.
is that facilitators and scribes have been able to consolidate.
No, in order. Thank you.
Thank you.
Across the world, alcohol consumption and harm are on the rise. And since the COVID-19 pandemic, deaths from alcohol rose to their highest level on record in the UK. Despite an abundance of evidence showing how to reduce alcohol consumption and harm, the alcohol industry has been a major barrier to progress and has slowed or prevented meaningful change. The alcohol industry has a profound effect on our health by influencing public policy to protect their financial interests. But how do they do this? And who are the key players within the alcohol industry?
The alcohol industry spends billions trying to prevent
the implementation of effective alcohol policies that we know will reduce alcohol-related harms. And the reason they do this is because they fear that these policies reduce profits. So the main ways in which they try to prevent these policies being implemented are extensive lobbying of governments, including the UK government, building relationships with policymakers, and funding scientific research to support policies that promote commercial rather than public health interests.
The alcohol industry is dominated by a group of multi-billion-pound companies. Over the past few decades, the industry has become increasingly consolidated, with far fewer companies accounting for an ever-increasing share of industry activity and revenue. The biggest companies globally are AB InBev, Diageo, Heineken, Molson Coors, Pernod Ricard, Carlsberg, and Asahi. Their brands are well known, widely marketed, and sold across the world, and include Stella Artois, Smirnoff, Amstel, Johnny Walker, Kronenbourg, and Campo Viejo. These predominantly European companies amass huge profits each year. For instance, in 2022, AB InBev made $6 billion in profit alone, Diageo £4.4 billion, Heineken 4.3 billion euros, Molson Coors 3.7 billion dollars, Pernod Ricard 3 billion euros, and Carlsberg made 1.4 billion pounds in profit. The global alcoholic drinks market is worth around 1.17 trillion US dollars in revenue. That's more than the GDP of 179 countries, meaning only 16 countries in the world have a higher GDP than the alcohol industry makes in revenue each year. These revenue and profits are at the expense of people's health.
So in England, 68% of alcohol industry revenue comes from people drinking above the chief medical officer's guideline levels, and 23% comes from those drinking at extremely harmful levels. So a lot of the money that they make ultimately comes from those who are drinking at levels that are hazardous or harmful to their health. And in an analysis that we did, we calculated that if people were to stick to the guidelines, alcohol industry revenue would fall by about 2/5, 38% in all.
So the industry relies on consumption that damages people's health in order to make profit for shareholders. And along with most private businesses, the alcohol industry's primary responsibility is to deliver these profits to shareholders. Alcohol industry growth and profit can come in three ways. One, by encouraging people who already drink to drink more. This is often by marketing new occasions to drink. Two, by encouraging more people to drink. This often means targeting low and middle income countries and lower drinking parts of the population, such as women and young people. The latter referred to by one alcohol brand as the heavy using loyalists of tomorrow. And three, by encouraging people to drink more expensive drinks, so-called premiumization, which is particularly done in Western markets due to higher levels of disposable income. The industry influences public policy, including health policy, in a number of creative ways as part of their corporate strategies to protect profits. Of course, if Diageo or Heineken were to blatantly push an agenda implying that alcohol isn't harmful, they would likely find it difficult to convince people due to a clear conflict of interest. However, instead, they push their agenda and preferred narrative by setting up and funding both trade associations and SAPROs, or social aspects and public relations organisations. Trade associations are usually commercially focused on issues such as tax, marketing and regulation. Examples of trade bodies include the Scotch Whisky Association and the Wine and Spirit Trade Association. SAPROs have greater direct overlap with public health as they focus on issues such as research, alcohol control policies, and underage drinking. Examples of SAPROs include the Portman Group and DrinkAware.
So SAPROs, social aspect, public relations organisations, are organisations which the alcohol industry funds, which take forward its preferred responsible drinking messages. So in fact, they're an important vehicle for putting that industry messaging out there. Big part of their activities, that includes organisations like DrinkAware, Ireland, Drinkwise in Australia, is to purportedly provide health information to the public on alcohol harms. So this is a big part of their mission. Unfortunately, again, the information that they provide to the public is misleading, partial, and it's characterized by what's sometimes called strategic ambiguity. So you get a lot of text messages, but they would say that they have a strong educational focus as organizations, but in fact, when we've analyzed the content of the materials, these educational materials that they use, including in schools, material is deeply concerning. So the SAP rules themselves are also a vehicle for alcohol industry misinformation.
These groups, whether trade association or SAPRO, play down alcohol harm and minimise attention on alcohol in relation to public concerns, such as cancer or the cardiovascular harm of alcohol.
We've seen across organisations like Drinkaware, Drinkwise, Educaku in Quebec, and other organisations that they like to avoid, if possible, mentioning the risk of cancer. If they have to mention the risk of cancer, they will then claim that will point to the fact that there are lots of other things that cause cancer. So it's almost like diluting the information by saying, well, yeah, alcohol causes cancer, but look at all these other things. Genetics is a particularly common one, which they will point to, family risks. And the other aspect of misinformation is to avoid mentioning the risk of breast cancer. The alcohol industry particularly does not want consumers, particularly female consumers, to be well appraised of the risk of breast cancer.
One of the core framings of the alcohol industry relates to individual responsibility, in which they deflect attention away from their product and the harm it causes to people's behaviour. By emphasising the importance of personal responsibility and individual judgment in consuming alcohol, the industry can say that their products aren't the problem. The problem is people not using them properly and drinking irresponsibly.
So this is a key part of the alcohol industry strategy, to deflect attention from the role and the responsibility of the industry in creating harms onto the individual. So it's a necessary part of ensuring that any individual harms, individual level harms, the responsibility for those are passed on to the consumer themselves. So that then leads to the emphasis in alcohol industry messaging on drink responsibly and responsible drinking and so on. So it ensures very much that there is a deflection from the responsibility of the industry, which is where our attention should be, onto the responsibility of individuals.
Yet the industry never clarifies what responsible drinking even means, and this binary outlook of the sensible majority versus the problem minority is damaging and stigmatizing. Alcohol is an addictive and health-damaging product, and there is no safe level of consumption. To suggest there is a sensible drinking majority implies there is a safe level. To suggest there is a problem minority implies alcohol isn't an addictive substance that has been normalized in most societies across the world. Yet the industry continues to use this responsibility tactic to resist broader structural population-based measures, such as raising alcohol taxes or restricting marketing.
Thank you very much, colleagues. It's Reverend Sokani speaking now. Right now, the main facilitator. I welcome all our team. We want to also welcome all the role players. Thank you very much for taking part in our group discussions. And now we're still on the theme that says shared responsibility, collective actions, lasting impact. So thank you very much, colleagues, for sharing the other videos. It's also inspire us really. And then there is somehow that we need to have time to look at. Thank you so much, colleagues. I think we are going to continue with the reportees' feedback. Just a final reflection. And then remember, we got a 6 room or groups, and I'm going to allow only 10 minutes. I'm going to give only 10 minutes each and every group just to present. And then I don't know who's ready right now so that I can give them a chance. Room 1, are you also ready? The platform is yours. Hello? Hello, colleagues? Hello?
Yes, we can hear you, Mfundisi.
Yes, yes.
We
yes.
can hear you.
Okay, thank you very much. I've just welcomed each and every one of you colleagues, and then this is time for a feedback, a final reflection, and then for reporting back. And I'm gonna give only 10 minutes for each group to present. Thank you very much also for sharing the video. It sounded a lot to us. It's just that now time is not on our side. And thank you very much for that. I don't know who's ready right now to give us a report. Group 1, if you are ready, you'll indicate. Room 1 or room 2, if you are ready, let us begin with the room 1. Room 1, are you ready? Rapporteurs, room 1, are you ready to present? The podium is yours.
Reverend Sokana, if they're not ready, can we do the report back? Can we do ours?
Okay.
Room 4.
Okay. And then room 2.
We are ready, Mfundisi.
Okay, thank you very much. I'm gonna give you a chance. The podium is yours now.
Thank you. Ian?
Remember, on room 2, it's a civil society, CBOs, NGOs, FBOs that were also debate and make some of the input on the final draft. Yes.
Thank you very much, Reverend. Yes, so in room 2, just to talk through what's on the page in front of you. In terms of new strategies for the sector, it was quite overwhelming that we feel that mental health integration programs must be a strategy for the new development plan. This on the back of the knowledge and understanding from all of the research and evidence that substance use is very, very often linked with mental health issues in our clients, and integrating mental health programs into the system will strengthen it and be beneficial for all of our clients. The second thing that we agreed on is that to improve the existing strategies, we need to lean more on evidence-based prevention programs. This is evidence-based. When I say evidence-based, I refer to very often randomized controlled trials that have proven that a specific intervention works. And these are relatively easy to roll out with a little bit of training for the social workers that are going to be running those programs. And then other methods also need to be considered where certain interventions are not necessarily affordable or accessible. And then in terms of clarity and alignment, in terms of the previous NDMP, it was generally agreed that, the goals are clear and the targets are largely realistic. However, more funding is definitely required, because if we can get more funding, we have more access to social workers, and with those resources, then we can reach more people. And then next, do the goals of the sector and the department, do they fit well with how our sector is resourced? And we all agreed that it is indeed the goals align. And then a couple of gaps that we highlighted. What is missing is we found that collaboration and coordination between different stakeholders and role players in the sector can be improved, and maybe a framework can be put in place to facilitate that. That will lead to better cohesion and agreement on what constitutes. Sorry, I'll just back that up again. And then I think we need to be very specific about what constitutes evidence-based prevention and treatment within our sector, so that we can all be speaking the same language when we're talking to our clients and when we're providing treatment. There are structures that exist, the PSAFs and the LDACs, but there's always been a challenge in making it work, and we need to be a bit more deliberate about how we do that. And then what can we commit to? Community implementation of proper educational programs to educate young people on the harmful effects of substances and drugs to prevent them from starting use. I know a lot of us do a lot of that work in the early intervention programs that we're all running. Thank you.
Okay, thank you very much, Ian. If you are done, I don't know whether are we going to allow some questions and clarity? And if we do have some clarity or questions, I'm going to also allow 2 members if there is any questions. Is there any questions? Okay, silent means consent. Right, can we go to the next room? Right, room 3.
Hi, everyone.
Room 3, are you ready?
Yes, I am.
Thank you very much. The podium is yours.
Well, thanks, man. So in room 3, we spoke about research and the role research would play in the substance use. So I think that we all came to consensus immediately when we got into our room is that we recommend that there should definitely be an audit of substance use disorder services in the country. So we need to do an audit of what prevention services are available in the country, what treatment services are available, and what recovery support services are available in the country at the moment along the full spectrum of the continuum of care. So we need to have a baseline knowledge of exactly what's happening in the country in terms of prevention. For example, who's providing prevention services in the country, and what kind of prevention services are there? Are they evidence-based? What exactly are those interventions? What do they entail? And I think we need to be collaborative, and it's something that perhaps the SAMRC can take on this audit alongside other stakeholders like the CDA, DSD, and other stakeholders. So that's a very important first step, because until we have a baseline knowledge of what's happening in the country, we can't just we can't expand services. We also need to do research is crucial to facilitate policy work and response work. So research should always be collaborative, like I said, alongside NGOs, tertiary institutions, and other organizations as well. So NGOs are, although they're non-governmental, they should preferably be aligned with like tertiary institutions to evaluate impact of their programs. Another thing that we came across is, just get my document, is capacity building for local community and family structures on addiction and recovery services and systems. So we kind of identified that that's a huge challenge, and a lot of the research has been done into treatment organizations, but not enough research has been done into capacity building and the effects thereof for local community members and family structures. Let's see what's next. So we need to also expand the scope of data collection beyond just the can-do treatment data to also include prevention service data as well as recovery support data. I think one thing that really was kind of fundamental in all this research that we've been speaking about is the challenge of funding. So there's so many researchers and institutions that want to do research on substance use, but there is no funding available for that. So I think we need to really look at the funding mechanisms for research in this field. Something that I was particularly passionate about was the use of recovery support system services. And recovery support services are non-clinical services that assist individuals and families working towards recovery from substance use disorders. So they're typically viewed as post-treatment, but recovery support services within the construct of recovery-orientated systems of care can be offered before, during, or even in lieu of treatment. So that approach can really support it's inclusive of pre-treatment as well as promotion of resiliency, prevention, and early or brief interventions. And I think that's something that we need to be looking at as a country and look at the research and do research with regards to recovery support services in local communities. What else did we chat about? We spoke extensively on research for fetal alcohol spectrum disorders, and that should be a priority concern for the substance use field and for departments of health, etc. So research should really include the drivers of alcohol use during pregnancy and epidemiological studies in more areas. And that's kind of been a big conversation piece in our group as well. Let me just think. There was also we need to also strengthen research on the chemical analysis of the substances and drug testing regime in South Africa. And this is specifically with relation to synthetic drugs. We found that that's becoming quite a huge problem, and we don't have the necessary chemical analysis and drug testing availability for synthetic substances in our communities. And I think I've covered everything. Yeah, I think I've covered everything. Thanks.
Thank you very much, Warren, for your presentations. I don't know whether do we have any clarity and questions from the ground. Do we have any questions or addition?
I just want to say thank you, Warren. I think you said everything very well. I just want to hammer home the point that we must explicitly refer to fetal alcohol spectrum disorder as a priority in the National Drug Master Plan. Please, that is one of the most important things I feel that can come from this engagement. Thank you.
Thank you very much, Lord, for additions. Any additions or questions? Yes.
Ref, so can I have my hand up? I just
Okay.
didn't hear the issue about the repository, the warehouse which should be a repository for information, because we are talking also in the space of research, that even research that is not done by or facilitated by the CDA, we need to be able to have that repository center. And not only that, even for the resources that are available for research, because we keep on saying there's no money for research, yet there are pockets of research that could be consolidated to be able to have a national research, even across universities of this country, for example, or working with other research institutions. So that repository house would be of significance. Thank you.
Right, thank you very much, Memamue. I don't know whether from the group do you want to add on what Memamue have said or respond?
Yeah, I don't have any response, but perhaps Prof. Pelmos, do you have anything to say with that?
not really, because the focus of the discussion was more on not really internal, but it was more on working collaboratively with different sectors and how to prioritize issues of research in the country rather than within a specific sector. Thanks.
Yes. Thank you very much. I think that one we can put it as the one of the plenary repository, because now this is a very important center in the sector of the research. It plays a very important role. I think we can just maybe place on the plenary where it can suit for us. I don't know whether do we have anything. Are we done in the group 3? Right. If we are done, colleagues, can we continue to the next group? Room 4.
Thank you, Reverend Sokana. So we weren't many in our group. There was just the 4 of us, and our scribe didn't show up. So I offered to be the scribe for the law enforcement and regulatory bodies group. So I don't know if I need to share my screen. Do I need to share it, or can I just speak?
Yes. Okay.
All right. All right, I'll just speak then. So under new strategies, so we came up with 3 and then highlighted 2 specific ones. So the 3 strategies, the new strategies that the law enforcement sector proposes is to target suppliers using community intelligence rather than people who use drugs, vetting of criminal justice system personnel to avoid corruption, and to strengthen internal disciplinary functions in dealing with corrupt officials. And then the 2 our final answers or responses were that we would like to prioritize vetting of criminal justice system personnel and to strengthen internal disciplinary functions, but also to implement non-custodial measures for minor non-violent drug offenses aligned with UNODC guidance, and invest in specialized training for police on targeting suppliers of drugs. The second part of that question was, if anything can be improved in the existing strategies, please consider all 7 goals and that apply to each department. So the 2 areas, or the 1 area that we decided to focus on, was the capacitation of CJS personnel to include substance use models in their respective colleges. Existing syllabus should be well integrated with public health approaches to drug use and not only focus on punitive measures. And then under clarity and alignment, we had a discussion there where we say that the goals are generally clear, but not always translated into actionable, measurable plans. Implementation frameworks need to be strengthened to improve clarity and accountability. And then there was also a discussion around there not being continuity with implementation plans, as focal persons usually change. So our final recommendation there was that while some goals align with law enforcement mandates, others require capacity building, legal reform, and resource allocation, as well as accountability. More investment in training, infrastructure, and cross-departmental collaboration is necessary to fully implement the goals. And the second part of that point was, do the goals the sector or department implement fit well with your sector's resource roles? So there we said that the fact that the NDMP is not costed makes it very difficult to hold certain government departments accountable. So we propose that the plan should be costed so that each relevant department should be able to report on how much has been spent to address substance use, so that the responsibility does not only rely on SAPS for this particular goal. The gaps that we identified, so there was 2 parts. So who is missing? We said traditional leadership, faith-based organizations, CPFs and LDECs, civil society organizations and communities most affected by drug use and policing, youth and gender-focused voices, and then data and research institutions. This is mostly around like collaboration in addressing supply reduction. We identified that the goal itself is very strictly and seems to really focus more on security cluster and makes very little mention on the collaboration of communities and other institutions beyond the security cluster. What is missing? Forensic labs and mobile forensic labs specifically. There was an idea that the four of us in the group would sell this idea to government and hopefully be able to implement mobile forensic labs. Capacitation of CJS, so criminal justice system personnel, so the NPA and law enforcement officers, particularly around convicting of drug trafficking cases, but also to be able to carry out their efforts. So we need more capacity there. Legal reform and implementation of adequate or sufficient diversion programs. But the biggest priority that we saw there was that we need to really look at our legal reforms. We then had a discussion around prison populations. So currently our prisons are overpopulated with people that are there for minor drug offenses. And so if we're able to review our policy or legislation around drug use for personal use, for example, possession, then we should be able to address the prison overpopulation issue. And so our main priority from the gaps area was the legal reform aspect and the implementation of diversion programs, where there's a real need to review our legislation. And then commitments. So we made these commitments on behalf of SAPS and maybe other clusters, but what the members of the group committed to, we did have SAPS in the group, so this is the recommendation for SAPS. It wasn't just from civil society, was that they commit to reducing drug-related arrests for personal use by 50% by 2030, commit to increasing drug-related arrests for supply or trafficking, commit to increasing conviction rates for drug trafficking. This is a commitment particularly for NPA. We didn't want to exclude commitments for other regulatory bodies, but we figured we should. Protection of vulnerable populations and community safety, to strengthen DDM processes in order to strengthen partnerships and collaborations between stakeholders to address substance use, and then training of criminal justice personnel on public health dimensions of drug use. That's all. Thank you.
Thank you very much, Charity Monareng, for the presentations. I don't know, do we have any addition from the group? Anything else that you want to add before I can open the questions platform for people to ask any questions? Okay.
We are covered.
Okay, you are covered. And then do we have any questions, colleagues? Any questions on the law enforcement and regulatory bodies, a group? If people are still also covered, can we go to the next room or a group? Group 5.
Sorry, Chairman, some question here.
Okay. Yes, the podium is yours.
Okay, I would like to ask a question if maybe the law enforcement group have discussed. Did they discuss the previous convictions of cannabis related arrests that today still hang on our people because they are now being unable to access job opportunities because of records that were made through those arrests? I don't know if I'm clear there.
Yeah.
Yes, okay, man. And then can we hear from the group? Any response?
So I'll respond from what I know, and then maybe the rest of the group can add. So according to the cannabis bill, cannabis convictions or criminal records will be expunged. So it's a matter of going to like a legal clinic or I think the Center in Pretoria to get your criminal record expunged. It's a free process. So people just need to actually go and do that. But there is provision within the bill that says that people that were convicted for cannabis offenses, their criminal records will be expunged. So this is a process that is currently ongoing, but no, you don't have to pay for it, and your criminal record gets expunged automatically. Maybe Prof. Palmos and the law enforcement group can also add on that.
Okay, thank you very much. Any addition, Paul or General Matonzi? Okay, means people are covered on the questions. All right, thank you very much for asking questions on this group. Thank you very much for your contributions. We now go to the next room, room 5, which is a youth. Your room 5, are you ready? The podium is yours.
Ndiyabulisa Nyawontle. Let me observe all protocol. Igama lam ndinguMxazi, representing the city of Johannesburg as the chairperson there. I will be presenting on the youth sector. So may I proceed?
Yes, class.
What are the new strategies that we can review? What we said here as a group, that there's no need to reinvent the wheel. However, we need to reinforce the current strategies within the plan and to ensure that the youth voice is prioritized. Prioritizing the youth voice, it means they need to find a way into serving into the structure of the CDA, and also on the ground level to ensure that they also participate in the local drug action committees. But we also need to ensure that there's realignment on the programs. And that will also assist in preventative strategies on the children and youth as the vulnerable group. So what we are saying, now, of course, we need to catch them while they're still young. So the youth factor is very much important. What can be improved? So we said, particularly goal 1 and goal 7, there is a room for improvement there. We know that goal 1 talks of the preventative and goal 7 is talking about economic. So in that aspect, we are saying, within the liquor industry, asizwe silence, we are saying it must be censored more. And we are saying these companies must support the youth programs, find a way to support their youth programs through their CSI initiatives. So with that, of course, there should be innovative programs that are supported. And I guess if unufaka a percentage, because we know that there is a percentage that they are receiving. So at least from the percentage of the coffers that they receive, they must also pop up 1% allocated to make sure that they sponsor these programs. And are the current goals clear and achievable? So the current goals were not clear, although we did say definitely they can be achievable, but they were not achieved. So there needs to be a change in terms of the strategy. On the focus must be on the youth, and also there should be researches, and those researches, must answer a question of what drives the youth to be involved into these substances. So the government system must also support the improvement of the mental health, because most of these young people are suffering with the disease of mental health as well. Hence, we also see the challenges of young people committing suicide. Even there's a number of young people committing suicide who are in the universities as well. So there is that challenge. So there should also be youth capacitation through entrepreneurship, mentorship, and coaching. So that's what we think, we can do in terms of ensuring that we improve. So then the question also is that the goals implemented, do they fit well within the sector? So we said the goals implemented now in the current plan, they do not really fit well. However, if they are realigned, they could definitely fit well, because if there's adjustment and there's also that capacitation and there's improvement, they could definitely fit well. But at this current juncture, with the plan up until 2024, definitely they did not really fit well. And who and what is missing? Of course, we are saying youth is missing. Kunale say eti nothing without us, about us. As you can see, even within the room, bekungekho umuntu omtsha. Bekule youth endala. We have old young people who are participating in this group. So we are saying a coordinated and coherent approach and collective intervention to deal with issues such as alcohol abuse. It's really important so that we can do that. So that is what is missing in this place. And what can the sector commit to? I think we are saying there should be youth participation. And also, as the sector, we are committing to ensure that there's measurable targets which must be achieved. But specifically, we are saying they are committing to a decrease of a number of youth using substance 5% annually. By calculator, Leo, I think by 2030 we should be at least about 25% decrease. What is the recommendation from the group? There's a recommendation that there should be youth engagement, just as we have this stakeholder engagement during the review process. So there should be a youth indaba that should also be happening during the review process. So you can see that a number of young people is limited by Ngosan. I thank you.
Thank you very much, Tatumzwake, for your presentations. Yes, of course, what you have said, youth are now, there is a gap of youth that are missing really. So we need to make sure that now to any reviewing, to any act or legislator, we make sure that now youth are taking part on that space. It is true, but I don't know what other members of the group would like to add on what Tatumzwake have said. Do we have any addition? If not, thank you very much. Can I have any questions, colleagues? Do we have any questions on the presentations? Right, thank you very much. Silence means consent. Let us go to the next group, the room 6, the Sunput. Room 6, if they are still with us. Sunput, room 6.
Thank you very much, Reverend, honorable guests and esteemed colleagues. Thank you so much for this opportunity to address you on behalf of Room 6, classified under P. Wood. The assignment to give input for the National Drug Master Plan is well understood. And as a group collective, we would like to see the upcoming National Drug Master Plan draft include real-life experience under the mantra, nothing for us without us. The strategic objectives of the National Drug Master Plan should align with our realities. It was proposed that input as a sector should be harm reduction orientated and that this should be considered a primary objective. Furthermore, in relation to the recommendations, we need social reintegration for people who use drugs. This should include access to shelters, ablution and hygienic facilities, skills development courses and other services with an emphasis on economical opportunities. Secondly, harm reduction and health promotion. The first suggestion was to support activism for PWD who experience various issues like discrimination and a lack of access to basic services that needs to be urgently addressed. Integration and training of various other institution staff members should be considered and should address the treatment of PWD community members. Furthermore, policy speaking to treatment and harm reduction should be identified and categorized under individual categories, specifically speaking to key PWD population, with further emphasis on human rights to be considered. Furthermore, we would propose a draft to decriminalize personal use or possession, to promote alternatives to imprisonment under the same mantra, support, don't punish. We want attention paid to we suggest or would propose that attention be paid to the criminal records of people who use drugs, as this severely hinders the patient's ability to successfully recover and be reintegrated into society. The function roles of PWD sector relating to the National Drug Master Plan should be implemented and include monitoring and accountability. The role and function should include PWD community input and contributions. The National Drug Master Plan should adopt the CLA in the National Drug Master Plan. Institutional mechanisms to support the PWD community. It was proposed that the Central Drug Authorities should establish a technical group that should be PWD-led. The function will be to guide policy and the implementation thereof. We would propose to formalize the PWD seat in the Central Drug Authority, PDACs and LDACs. This will be to address policy reform. The issue of failure to deliver services due to PWD not having ID documents is a main concern, and alternative avenues to assist PWD community members to access services without such valid identification should be considered. Human rights and legal reform, governance and accountability as a tool for legal reform to ensure that there is a formal representation in all government drug structures. This should include monitoring mechanisms. Furthermore, legal aid should be made available to PWD community members. We would also propose desensitization of service delivery personnel and staff. An example of this would be the law enforcement, health professionals, and also the justice system representatives. And we would propose that they receive training on how to treat PWD community members, as well as all the issues that we face. Harm reduction services and therapy programs should also be made, or a further recommendation that harm reduction services and therapy programs be made available to prisoners, and that guidance for pre-release prisoners should be made a priority. Okay, and then just before I conclude, let me just, as a summary, read the groups. Sorry for the delay. Let me just quickly read the group's institutional and structural recommendations. Firstly, to embed harm reduction in the National Drug Master Plan as a standalone strategic pillar, not just under demand reduction. Secondly, to allocate dedicated government funding streams for harm reduction via NDOH, SANAC, and the Department of Social Development. Thirdly, to formalize PWD seats in CDA, PDACs, LDACs, as I have mentioned earlier. To establish legal protections for harm reduction clients. That is with regards to PWD community members using or being in possession of, for example, needles and syringes, that they do not be arrested for being in possession of such equipment. And then fourthly, to scale up training programs for SAPS, social workers, and health staff on harm reduction principles. I thank you kindly for your time.
Thank you very much, Baron Beggs, for your presentations. This is a critical stakeholders, colleagues. Thank you very much with your inputs, with your presentations. I don't know whether do we have any additional, any addition from the group before we can make the podium available for questions. Is there any additions? Thank you very much. If not, we now go to any questions. Do we have any questions, colleagues?
Thank you, Reverend. Yeah, as an input, I think in a short term, I think all these structures, if they can consider co-opting, PUIT non-representative from their respective LDEX and the likes, like we have done in Ekurhuleni, where we're able to co-opt, in the meantime, because as I've just alluded, Reverend Guti, the key, but sadly, the PUIT sector is not participating in all these very important structures. But I'm glad that there's a submission in that regard. But I was saying in the short term. Thank you so much.
Thank you very much, Tatugama, with your inputs. Colleagues, I don't know whether do we have any other questions. If not, we can go to the room one, or the room one, to give them the chance, the podium, to report if they are now ready on the national and the provincial government department. Are they ready?
Yes, we are ready, Chairperson. Thank you.
Okay, the podium is yours.
Thank you so much, Chairperson, and good day, colleagues. We are room one, which is national and provincial government departments. Just to say, Chairperson, before I start with my presentation, that the inputs that will be shared here today will only be from provincial, DSD, and Gauteng education. The national departments, we didn't have any representation from the national departments. Thank you, Chair. Just to start with our presentation, I'm going to go through provinces, Chairperson. The first province is going to be Western Cape, their inputs that they gave us in room one. Western Cape DSD have substance abuse programs which are integrated. They are integrating with other programs. Your substance abuse, it's social crime prevention and VEP, and they have centralized interventions. The Western Cape also have forums, which is they have a forum which is a key driver to services, and it forms all their actions together with other stakeholders on issues around substance abuse and other related changes. Western Cape also has mentioned that they would like to have a depoliticization of the leadership of LDEX. Also that the public sector to be more involved and available, and also that due to lack of staff, there is a need for long-term sustainability of intervention programs, as well as impact on affected families. Moving right along to the Mpumalanga Chairperson. Mpumalanga indicated that there is a challenge with resource allocation. Substance abuse is a priority in the province, but allocation of resources does not indicate that substance abuse is a priority. They've also indicated that there are structures, but there is no person who is dedicated at coordinating the substance use in the province. They also indicated that there is a need to integrate with other programs internally within the department and with other departments as well. And this needs to come out strongly in the National Drug Master Plan. They've also indicated there's a need for dedicated people to drive the establishment of structures in the province. And then moving right along to KZN chairperson. KZN, they indicated that they do have they are using the DDM model, and then the province is the province is implementing the DDM model, although substance abuse is still a challenge because the model has its own focus and there is no interest in escalating substance abuse issues in the DDM model. The National Drug Master Plan needs to enforce the DDM model on the LDEX and the PSAVs. The goals are implemented fully. The 7 goals are implemented fully in the province. The resource allocation also, chairperson, is a challenge in the province. There is no funding. And this needs to come out clearly as well in the National Drug Master Plan to indicate for proper implementation. There is a need to have allocate resource allocation. The recommendations that the province made, or before going to the recommendation, chairperson, KZN also indicated that localizing the research and the intervention must be considered as opportunity to increase employability and capacity building, e.g. employment of youth can be capacitated and paid a stipend towards peer support and education. The province indicated that costing is critical for the implementation of the National Drug Master Plan. The recommendation the province made, the National Drug Master Plan must be costed appropriately, and then also the IDPs of the municipality must be integrated and to come strong in the National Drug Master Plan. They must be clearly stated in the National Drug Master Plan. We also had an NGO, which is Youth Empowerment NGO. The NGO raised that the research and policies and other government documents are not implementable because they are complex for people in communities. The communities, chairperson, they need a simple document that is responsive to the needs of the community and the users. The NGO also mentioned that ground-based research, which is localized, is vital in this country, as well as ward-based awareness and education. The NGO also mentioned the IDPs, that the IDP should include the initiative that will be driven in the district or municipality and indicate that it's a departmental initiative. That whatever that they are doing in the district's chairperson and in the municipality, they also need to indicate that it's a government department initiative. Also, they indicated that there's a need to educate ward community members and capacitate them to deal with the substance abuse problem. Moving right along, chairperson, Gauteng Education also indicated that what they basically do, they identify learners that need services, and then the district would help them with referrals, referring the learners to the appropriate centers. And then they would also have monthly reports on the progress of the learners that are accessing the services, but there is no early intervention programs. The Gauteng Education also mentioned that parents do come to schools to indicate if they have issues or they would like to have help with their child as a user, but the schools encourage that it has to be a voluntary admission, since they have realized that if it is not voluntary, the learner at times does not commit to the program that they are being offered. Last but not least, chairperson, it's Gauteng Department, FF, Ribeira, the treatment center, where they indicated a challenge that their admission are politically motivated. And this is a result that it's after outreach most of the time that they would be getting people that are being referred to them by the offices of the politicians. And this, when it was discussed, it was we realize that also that we have a red tape where admissions are concerned. We have red tape where admission policies are concerned because they are cumbersome, and because of limited social workers as well, it leads to long waiting periods. So that can also be what causes the politically motivated admissions. We've said that in the group chairperson that the policy is still in a draft form and will be able to assist us in dealing with admission processes. And then the community will be able to get the treatment in large expected numbers once the policy is in place. And this needs to be included in the National Drug Master Plan as well, Chairperson, that once the policy is in place, then with the admission process will be easier to deal with. Thank you so much, Chairperson. I believe that the people that I was with in the group 1, they can also have additions, Chairperson, if they can be given the opportunity. Thank you so much.
Yes, thank you very much, Ms. Melarato, for your presentations. And thank you very much for indicating that how many stakeholders were there. I'm still very curious about why the national was not part, but I'm sure they were invited and then to take part in our meeting. Thank you very much. And thank you also very much for the chat messages, and I will take into considerations on that. Do we have any additions, colleagues? The group, any additions?
Yes.
We thought we can ask people questions. Yes. Okay. Okay. The podium
Yes,
is yours.
please.
Yes.
Thank you very much.
Just-
From Gauteng Department of Education, we'd like to put the addition that the prevention programs are in place, particularly in schools, whereby health promotions is assisting in terms of going into schools, particularly the health promotions in the municipalities, go into schools to talk about substance abuse disorders. They talk about different types of drugs. They talk about this and that from a very early age, from the primary school side. And in that, they assist in the learners understanding the challenges that can come along with using drugs. We also have multiple units within Gauteng Department of Education also working together in terms of assisting on prevention programs. Then using also the curriculum as well. And it works quite well, whereby we see the referrals working. But we are still struggling with voluntary referrals, particularly from our schools. We only see them when we are in campaigns. But nonetheless, we are working very well with Gauteng Department of Social Development and Department of Health in making sure that our children and our learners understand the dangers of using drugs. Thank you so much.
Thank you very much for your inputs, for your additions. I don't know whether colleagues, do we have any other additions?
Hello,
or anything?
Chairperson.
Yes, the podium is yours.
Thank you, Chairperson. I think one of the things, it's Zenzile Makushe from Department of Social Development, Mpumalanga.
Yes.
I think one
Yes,
of the
Zenzile.
issues that we have indicated as a group that we need to take note of is the issue of the detoxification services, as our scriber has presented in the issue of the admission guideline that is still under the process of being developed. We need also to look at the issue of the detoxification services, because some of the treatment centers don't provide a detox. However, the Act is saying the Department of Health must provide a detox. So the issue of detox, it's one issue that we said we need to look at. And then the other one, in terms of the DDM model, most provinces do have the DDM model, and they said we have agreed that it's going to be best if we can follow that, and if the SU program can find space so that in terms of the IDPs, they can be taken note of. Thank you.
Okay. Enkosi kakhulu Sisenzile. Thank you very much, colleagues. I don't know whether do we have any other questions and clarity? And I'm sure we are through now with all the rooms.
Just have one question, Chairperson.
Okay. Okay.
Yes,
Okay. The
hands
podium
are
is
up,
yours.
Chairs, yeah.
Yes, your podium is yours.
Chairperson, in terms of the Department of Education saying that they have preventative programs in place and that they are working, if you look at the statistics currently in substance abuse, I don't understand that statement. Is there any way that we are able to access statistics that they might be using to see what they are referring to? Because from what we've seen from the police statistics, criminal statistics, and young people in the schools and the level of drug abuse, I don't understand why the preventative measures that the schools currently have in place are working.
Okay, Mauritius.
Can-
I don't know whether do we have
Can I
somebody who can
respond?
assist? Yes,
Yeah.
okay,
Can
your
I
podium
just
is
give?
yours.
All right, thank
Yeah.
you. So far we are using the Kimoja program, and I was actually also trying to type in that the Kimoja program is also assisting, especially in the schools using the Kimoja coaches. They are the ones who go into schools and it's really coordinated by social development. And I want to believe that if these programs were not in place, more than half of our young people in Gauteng would be in drugs. And that is the extensive, for us is the extensive evidence that the programs are working. They may not be working as people expect, but with us, if less than, I don't even want to say 10%, less than 5% of the learners in high risk schools are using drugs, they are referred and they get help. We are quite satisfied. And when these programs like Kimoja are working, when the NGOs that are registered with social development are working, and we see good results from them, the stats can be there. Yes, they are there. Remember, they are community stats. They're not really school-based. And we see them as something that is working quite well. So let us also look at what works against what does not work, because remember, schools are there for teaching and learning. That is just the mandate, and most of the effect come from the local communities. But if the schools can withstand the challenges in the in the communities and make sure that at least more than 90% of the learners are not affected by the drugs, or even if some are affected by the drugs, but teaching and learning is taking place, and those that need help get help through different sources. That is exactly what we want, because the school's mandate is to teach and for the learners to learn. And let us not forget. And I'm really sorry that we are taking it that way, because if we are to entertain everything that comes along, the learners are going to entertain it as well. But the prevention programs seem to be working, particularly to aid education, because I am talking from the learner psychosocial support program, school health. And for us, something is really happening and something is working. Thank you.
Thank you very much, Mary, with your contributions. Thank you very much again, colleagues, all of you who have been contribute on the groups.
Well, I've had my end up for a very long time.
Okay. I'm sorry because I don't see on my side, but Kela, you can continue. Your podium is yours.
Okay, thank you, Chair. I think the critical thing that actually also came up, maybe we didn't capture it correctly, was the issue of community-based services and integration at the community level. And that starts with the research. I think Lerato mentioned the issue of research being up there and institution-based research. But what was raised in the group was the issue around local research that should then inform services at a local level to say what's required at a local level, and especially at what level. What are the things so that we are able to bring services and integration and planning closer to the people. And in that way, and I think what was being proposed there was also that the National Drug Master Plan must actually unpack the service integration at a local level to say what needs to happen at a local level. Because even with much as we say that we want to take it one step at a time, but you also need to realize that if you look at the metros, for instance, look at the local drug action committee, they're there in the metros. Your local communities where the services are required, where the pain is felt, and where information is required also. For instance, an example was made, if your child is starting to use drug, who do you go to? What do you do? And that information is not even easily available. And those are the solutions that can come from the communities themselves. So I think this is something that needs to be looked at in the National Drug Master Plan, because it was a very solid and concrete proposals. And also the simplification of document and making those documents easy to understand for members of the community, the policies easy to understand and to be translated in appropriate languages for the communities to have access to them. And I think this is something that we have not really, for instance, if you look at the National Drug Master Plan itself, the National Drug Master Plan is a very high-level document. Your provincial drug master plans are high-level document, and they only talk to government and not talk to the other stakeholders. So I think this is one of the key issues that was raised in the group, and we had the benefit of people that are operating at grassroots level as well, that have lived experiences around this. Thank you very much.
Thank you very much, Mamkela, for your contributions. Colleagues, we are now done with the questions. And
Sorry, Mfundisi.
okay,
Sorry,
okay.
Mfundisi. Before Metela, there were a number of hands that were up. Seki's hand is up, Chantel's hand was up, and then there was another one before Chantel. So,
thank you very much.
yeah, I think if you can entertain those ones, thank you.
Thank you very much for assisting me on that side, Chantel.
Thank you so much, Chair, and thank you, Dr. Zalia. Now, I was just making a note, Chair, that unfortunately, Lerato wasn't there to capture my bit when we were in the breakaway rooms, but just in a nutshell, it was literally just saying that head office here in Western Cape takes care of the funding, M&E registration, and the LDAX. But then the regions, and that's what what Lerato captured was the colleague from the regional offices. They deal with the statutory services for our clients, so they deal directly with the clients, whereas head office doesn't. They deal with the NGOs, the municipalities, etc. So we streamlined it in this way in the Western Cape, because the question and the group was, how does your department how's it aligned, the strategies is aligned with the National Drug Master Plan and the Act, because that is, we take our guidelines from the Act, and therefore I elaborated why the chapter 1 to 9 is taken care of by our substance use program at head office, and then in partnership with, of course, with the LDAX, and that's why I'm positioned there with them, because we actually work very well together in terms of they fund and register and M&E. So in a nutshell, the streamlining and allocating the resources in order to drive the PSF, in order so that the PSF can help the LDAX, is what the Western Cape DSD has done. So the colleagues from the region and local offices, unfortunately, because the metro is run by the city of Cape Town in terms of the LDAX structure, one also must remind ourselves that the metros in our country are very different to the rural areas. And I think the rural voice are missing here as well, to be honest with you, because I think the local offices in our regions, which is the municipalities, where the municipalities are, and I work very closely with, has got similar challenges to the metro, but they've even got more. And I think that that's why I think the DSD local officers, when you work with them outside the metros, they're actually very helpful. They're very on board. They really work well with the municipalities and the stakeholders, and the schools and health, etc. So I just want to make that distinction as well. And I think the IDPs with the municipalities play a critical role in this. So I just want to highlight that's all what I've captured. But just to encourage everybody to look at it, the multi-sectorial whole of society approach. And I think the one gentleman regarding the baseline, we haven't done baseline studies in a very long time in terms of so that we only depend on Sekendu's admissions to treatment data. That is where we get our trends like outlook from in terms of what is trending in your province, for example, in terms of admissions, what type of drugs, alcohol, what, so Sekende provides that. So the baseline school studies, I think we did in 2013, and then the youth strategy was emanating from that. So I think my last comment would be to encourage whoever that may be, where we can get funding for a baseline prevalence studies. Then we can determine whether or not our programs are actually making an impact. So yeah, so that's where I'd leave it. But thank you so much for the opportunity. And yeah, thank you so much.
Thank you very much, Ms. Chantel, for your inputs. I don't know whether do we have any on that side, Dr. Atalia?
Yes, Tsepi, Fundis.
Okay, okay, the podium is yours.
Thank you so much, Dr. Talia. Thank you, Reverend. Mine here, I think, is directed to room 1. Maybe they have commented on it. I may have missed it. I'm not sure. I am really just requesting or asking whether there are any efforts in the strategic plan to include the traditional authorities in our rural communities. Sorry. Because these are the leaders or the community that are the first point of contact when there are social issues in our rural communities. So I just want to know, what are the efforts? Is there anything, a concerted effort to include the traditional leaders or traditional authorities with these interventions? Because majority of the interventions, they really do not reach our far-flung areas or rural areas nationally. So that's what I would like to hear more. I'm interested in that. Thank you.
Okay, thank you very much, Metsepi. I don't know whether from the group 1, do we have any response from group 1?
Yeah, I could try.
Okay.
We really didn't delve into that. The issue of traditional leadership, but I can indicate that there's a lot of work going on with traditional leadership, and they've been very, very active in terms of issues around substance abuse. But also, as we're looking at the local government, the involvement of local government and the LDEX and what have you, they are participating in that process. And they are included in that process to say, how do we make the services better? But I think UDC can also add in terms of the involvement of local, of traditional leaders.
Yes, thank you very much, Mamkele. Do we have any additions?
Is it possible for me to comment?
Yes, okay, the podium is yours, yeah. Daisy?
Can I go ahead?
Yes, continue.
Okay,
Sorry,
so
I'm so sorry to interject. Mfundisi Carmen wanted to say something, but she couldn't raise her hand, and then her name came before Daisy.
Okay, can we allow him?
Yeah, thank you so much. I just want to make a comment as well and respond to the previous, I think it was with regards to the educators and the teachers and the situation that we have and we're experiencing. It's easy to say that teachers must teach and learners must learn, where we have teachers that is addicts, police that is addicts, that is using drugs. I'm involved in a case where a 13-year-old stabbed a teacher. And the police and the school made a case against the learner that is 13 years old without doing any assessments on them. So I fail to understand that we can say that it's not important. Is there any way that we have, or we can include the fact that even our teachers are addicts and they need to be tested regularly? Our police needs to be tested regularly. We are experiencing on the ground that all the people that are supposed to be servicing us as addicts as well, and they need assistance as well. So there's a huge gap there as well, especially in the rural areas where when we say that we're trying to educate parents, now you find that the entire family are addicts, from the mother, the father, and the children that are addicts as well in our communities. So how do we deal with that? Who do we make contact with? The stakeholders, and like I was saying, the consistency with regards to the LDACs, they don't play an active role in our communities where they share the information that they have and filter it through so that NPOs and NGOs like ourselves and the faith-based organizations, because I mean, surely there's the whole panel consists of SAPs and faith-based organizations and etc. But that information and the services that they provide is not being filtered into the community. There's no activities, there's no events, there's no awareness campaigns, there's nothing that's happening. And even in our schools as well, it's like I was saying, like with regards to drug-free world, because I represent drug-free world as well. We have educators' kits, and we've been struggling, and we've been really wanting to try and implement that in the school so that the teachers have a proper educators' kit, and it forms part of the curriculum. So I humbly just disagree with the fact that you can say learners are learners and teachers are teachers, because that is not what is happening in our community. And that is why we also find the violence in our school, the bullying. This is what is happening every day. And parents are not active enough on the SGBs as well. So this is something that I think definitely needs to be taken into consideration, that when we say it starts at home, but the problem actually starts at home and filters right through into schools. Thank you so much.
Thank you very much, Mayor Kamel. And I think that is true what you are saying. Really, there is a gap, a big gap there in terms of the traditional area, especially people who are on the farm. Really, there is a little bit a gap on that area. But now I think the NDMP, we need to make sure that now really we accommodate them, those areas. Thank you very much. I don't know whether do we have any speaker. I think it will be the last because the time is not on our side. If there's any other questions or any inputs.
Yes, can I come in, please?
Yes, that's the last speaker, please.
Okay. I just wanted to add on to what Princess Tepi was saying, that in group 2, in the breakaway session, I think that we did justice to talking to everything that drugs can do, and also issues of capacity building for the communities, because the challenges cuts across issues of GBV and femicide. Families are being broken down, and we did justice to that, issues of mental health among the youth. And I did bring about the issue of traditional authorities, and we also talked about collaboration, the importance of collaboration and capacity building for those who are working in these traditional authorities to assist with the implementation and the rollout of what the truth about drugs. Thank you very much.
Thank you very much, Medesi. Colleagues, let me end here. Thank you very much for your all inputs and all the chat, although I didn't have a chance to read some of the chat information, but it's recorded. And thank you very much for our facilitators, our scribes and rapporteurs who plays a role. Thank you very much. May God bless you. We now go to Mentimentors. I don't know, Dr. Sibe, are you going to also allow us maybe to give us just so that we can have 5 minutes or 10 minutes before we can go to the lunch? Can we go to Dr. Andrew?
Sure, if we'd like to do the Mentimeter quickly, what we've also are putting forward are any inputs that people might have around the mission and the vision of the NDMP. One of the things we were asked to put forward was around the separation of one of the pillars. So I'll put that forward. And that's currently the pillar that includes harm reduction and treatment under one pillar, or if it should be a separate pillar. So if people aren't attached again to their devices, there's the QR code. Also in the chat, we will include it. I must just see if I can get it. Join instruction. Okay, I'll put the link also into the chat for this QR code. So the question is just a yes, no, what people think about the separation of harm reduction and treatment into separate pillars. So far we've got 10 people responding. On the call, we have got, what's our total? We've got 75 participants on. Sorry, so Captain Lippert, please use the QR code. It's here on the bottom left. So can someone confirm that the screen is sharing? You should be able to see it. The QR code should be on your screen that you can.
Yes.
Yeah.
Sorry,
Yes,
yes,
we can
able to
see.
see it.
Okay, so I think at the moment there's a question about what will entail. It'll entail, I think, the understanding of harm reduction, but currently it's linked and is part of treatment. So it's just to get a sense from this group. So if you're on your phone, Captain Lippert, you should be able to you should be able to look in your chat on your phone, and in the Zoom chat is the link, which I've posted above, and I'll post it again. And you should just be able to press that and it'll take you to the comment. We've got 31 responses and our total number so far of people is 76. So I don't know if we should wait for a few more responses. So we've at least got more than 50% of people responded.
We would encourage that, Dr. Andrew.
Yeah, please, can we ask people to, if you can't do that, you can type in menti.com. And then the number you put in is 89562493. We've got 33, so we'd like a couple more responses.
It looks like people are now encouraged to also respond. There they are coming.
We've not yet reached 50%. Can we encourage people before we move on to the next one? So, Michaela, I see that you put that comment in. What we would like you to do is to use the voting function. I see there are different people who are putting in, some saying yes, some saying no. And there are some reasons that people are putting in. So we've now reached over half. We'll move to the next one then. So the next question is just asking if there are any other particular changes that are needed to improve the existing pillars or goals. This is open text, so you can put in free writing. So Dr. Nklapo, the link is on the chat. I'll put it on again. If you've arrived late, maybe it doesn't show you, or later, it may not show you the preceding link. I'll put it in there again. Oh, sorry. It must be to everyone. Apologies. Does that work now? Thanks for the clarification. Apologies, I was personally messaging the CDA main host. Apologies about that. Okay, we're getting some feedback. People are saying that there are other changes. There's a specification that fetal alcohol syndrome disorder should be put as a separate and explicit goal. So I think the way the goals are currently framed is in terms of broad approaches, not necessarily the separate objectives within them. Okay, there's something around financing, around inclusion of people who use drugs, clear performance indicators and targets, family meetings and support. So we're getting a lot of suggestions just for the CDA Executive Committee. These may be able to fit within the existing goals, several of these things, because a lot of them are strategies and interventions, or just good practice about costing and funding. Okay. So we've captured those. Then the current vision of the National Drug Master Plan is a South Africa free of substance abuse. So the question is, should it stay the vision or should it change? If it should be changed, if you have any suggestions, you can put what the revised vision should be so that we can capture that as part of feedback. It's open text. Okay. We're getting a few responses saying that it should stay the same. Just noting that substance abuse is not recommended terminology in the global lexicon. Substance use disorder is the recommended text, or substance use condition is less stigmatizing. But the people who responded to say that it should. Okay, so there's someone who's saying that to consider changing it to substance use disorders. Okay, there are other people saying substance use disorder, keep the same. Okay, and there are other people acknowledging that it should align with international terminology. And abuse is not part of international recommended terminology. Okay, if there are any other people, we've got 18 responses, 19 responses. Okay, if there are any more and you haven't put in, you'll be able to. Then the next question, the current National Drug Master Plan has got a mission and the mission has been translated into the mechanisms in which the mission will be achieved. There are 4 components. One of the first component is mention of a balanced, integrated, and evidence-based approach to domestic drug use, misuse, and abuse. Are there any changes to this terminology? Also, you'll see here, these terms of drug use, misuse, and abuse are old terminology. It's not terminology recommended by the United Nations, which again uses the spectrum of ICD-11 codes and the terminology of substance use disorder. Okay, there are people talking about substance use disorder. People saying that the integrated and evidence-based approach is appropriate, but perhaps align with recommended terminology. Okay, so it seems that there's an acknowledgement that this intent or the statement is appropriate. The next one, also, even though we've moved on, if you haven't yet put in your comment, you'll be able to put it in. So there's a mention around shifting it to evidence-based to evidence-informed. Edward, please put it in the Mentimeter. I'll put up the code again, so that it's captured in one place. Okay, then the second part of the mission is around invest in building safe communities through appropriate drug prevention, impact mitigation strategies. So I think this terminology has been used instead of using harm reduction. So someone's saying that it shouldn't change, keep the same. If you do have a recommendation for change, please put it into your text so that we can. Okay, got 7 people's responses. 1 person proposing harm reduction. 2 people harm reduction. Evidence-based prevention. So there's a clarification here that also if we talk about prevention, it should also be about evidence-based or evidence-informed prevention and harm or impact mitigation. There's a mention of including whole of society approach. Also suggestions of harm reduction. Okay, we've got 22. If you haven't responded, there'll still be time for you before we move on to the next one. This is the third part of the mission, which is around the control of demand and supply. Apologies, that I probably captured that incorrectly. Doubt it says that. Let me just find the correct terminology. My apologies. Oh yeah, it is substances of abuse. So it should read control the demand of supply of substances of abuse and misuse. Sorry, I'll just make that quick change. Control the demand and supply of substances of abuse and misuse. So please, if there's a change required, please suggest the terminology. So notification of replacing abuse with substance use disorder. Okay, there's a major reframing that's provided here. Okay, we've only got 8 responses so far. Okay, so there's a suggestion to change substances to be around psychoactive substances, harmful substances. Okay, I'll move on to the last component, which is, this is the 4th component of the mission, which is around to effectively control substances for therapeutic use and the emergence of new psychoactive substances. Apologies about my typing here. I've done poorly. So it should be effectively control substances for therapeutic use and the emergence of new psychoactive substances. Okay. People are saying that it's fine. And people saying it shouldn't change, keep. So there's no mention here around increasing access to substances for treatment or medications. People are saying more mandatory measures are needed. Okay. Okay, mental health disorder in the statement. I think the intent of this statement is aligned to control and access to medications, and then and this is just around surveillance of new psychoactive substances. What did that say? This is fine. Did I miss a section on maintaining pharmacological control? So this section here is where kind of the aspects of SAPRA or elements of regulatory authorities would go. It's around access and control of medication, of substances, those that are under international control, but also of relevant drugs. Okay. PSAF and so it just seems that whatever the final mission statements are, that they must be very easy to understand and how it's implementable at the provincial and subnational level. I think that's a critique. Okay, so this is a very concrete suggestion, is the mission is too long. It should be short into one phrase, and then rather remove these 4 subcomponents and link them to the objectives of pillars. I think that would be a very clear approach, so that how often visions and missions are framed. So we've captured that for feedback to DSD and the CDA. Okay, so thank you very much. That's the end of that. So I'll stop sharing. I will print out the report from yesterday and today and send it through to the CDA Executive Committee. Thanks. Back to you, Chair.
Thank you very much, Dr. Sibe. Thank you very much for this item. Really, we want also to thank those who have contributed on that. This is really a strategic deep dives and sectoral commitment. Remember, we need to make sure that now everything with deep dives, really. Thank you very much, our Mentimeter facilitator, to make sure that people apply their mind on this particular area. Thank you so much. Colleagues, we're gonna go to the lunch. I'm gonna give you only 50 minutes. This is 2:10. I'm gonna give you only 15 minutes, and so that we can give the last 2 speakers chance to prepare for themselves, and then there will be some other 2 items afterwards, where it will be a plenary reflections by Lerato Makope. So now I think 15 minutes is enough to come back and finish with our stuff. Thank you so much, colleagues. Can we give us 15 minutes, all of us? Are we all agree?
We shall run, Rev. Thanks very much.
Thank you,
Yes.
thank you, thank you.
drinking. Another key tactic the industry uses in order to resist more effective measures, particularly trade associations, is to position the industry as being good for the economy. When minimum unit pricing was set to be introduced in Scotland from 2012, the Scotch Whisky Association took the Scottish Government to court to try to prevent the policy, arguing that it was trade restrictive and would damage the economy. After the measure was introduced, after a 6-year battle in the courts and millions of pounds of taxpayer money spent, no such economic damage played out, and the policy has successfully reduced alcohol deaths. The Scotch Whisky Association also lobbies for alcohol duty to be cut or frozen each year, arguing it would be good for the economy to support the alcohol industry. Cuts and freezes to duty between 2012 and 2019 led to an additional 2,000 deaths from alcohol in the UK, as alcohol became increasingly affordable. Alcohol control policies do aim to reduce population-level alcohol consumption, and a reduction in drinking could well affect the economy. However, research shows that reducing alcohol harm can support economic growth. For example, any reduction in spending on alcohol due to increased taxation would partly be offset by increased spending on other products. Research from the Fraser River Institute showed that a 10% increase in UK alcohol taxes, which would reduce alcohol consumption, could then be invested in other sectors and public services, and had the potential to increase national income by £850 million and increase employment by 17,000 jobs.
We then need to layer in the supply side labour market effects of reduction in alcohol consumption. So the health gains from lower alcohol consumption would then feed through to the economy in the shape of fewer people coming to work hungover and having their productivity impaired as a result, fewer people being off sick because of the health harms associated with alcohol, fewer people unemployed because their drinking makes it harder for them to hold down a job, and ultimately fewer people of working age dying because of alcohol-related causes. And all of those things are an unambiguous gain to the economy. I mean, they're obviously good for other reasons. They're probably more important, frankly, than the economy, but they are unambiguously good for the economy.
For decades, the alcohol industry has engaged in the funding of research in order to shape perceptions and spread doubt. Industry funding of research allows them to shape the research agenda and focus on industry framing of problems, such as focusing on individual issues and interventions. It also may pressurize researchers to produce findings that are beneficial to their funders. As recently as 2018, a major study on alcohol and cardiovascular health had to be cancelled after evidence was found of pro-industry bias in the awarding of the grant, the selection of the investigators, and the choice of research sites. The industry shapes the evidence base through sponsored research, selective research dissemination, and the discrediting of public health research. It also muddies and confuses public understanding of alcohol harms and pushes for ineffective policy measures.
The alcohol industry has funded scientific research for decades. It has tended to focus on early career researchers. So what we find is that small amounts of funding at the early stage of a career leads to perhaps more industry funding, more work with other industry funded researchers, and attendance at industry funded events. And so it has an influence over the whole course of a person's career.
The alcohol industry has for many years used similar tactics to those of the tobacco industry during the 1950s. This is referred to as the tobacco industry playbook and was a tactic the industry used to promote their product and spread misinformation about its health effects.
And so the tobacco industry engaged in practices that promoted denial of the harms of smoking, promoted doubt about the health harms associated with smoking, and criticised science that went against commercial interests and identified the harms of cigarette smoking. And today we're seeing that not only the alcohol industry, but also other industries such as gambling or the ultra-processed food industries, the oil industry, are also using some of these same tactics, which massively impact on public health.
If the industry hasn't managed to resist regulation by pushing the economic argument or by shaping perceptions through research, they position themselves as part of the solution by promoting self-regulation, partnerships with the government, and voluntary agreements. In the UK, this includes marketing and labelling. The industry-funded Portman Group is responsible for overseeing a marketing code of practice, which includes forbidding marketing material which may be appealing to children. However, analysis shows that these restrictions regularly fail to restrain marketers and do not protect vulnerable people from harmful alcohol marketing.
So the point of self-regulation and voluntary industry measures is to allow the industry to say to policymakers that, look, we're keeping our own house in order. You don't have to be too concerned about alcohol harms because we're doing all these great things. Look at all the activities we're engaged in. We fund charities. We engage in measures like the community alcohol partnerships. We're doing work in schools, although I think they sometimes like to keep quite quiet about that one because I don't think the public would be too impressed to know that the alcohol industry is teaching school children about alcohol and giving them this information.
The UK government's Public Health Responsibility Deal, launched in 2011, is a clear example of the failure of industry partnerships to improve public health. The deal, which aimed to tap into the potential for businesses and other organisations to improve public health and tackle health inequalities, allowed alcohol industry groups to dictate a series of public health pledges and communicate the results too. One of the pledges was to improve product labelling to help inform consumers. However, despite the Chief Medical Officer's drinking guidelines being updated in 2016, 6 years later, research by the Alcohol Health Alliance found a third of products still do not include the guidelines and labels. This relinquishing of control has allowed the alcohol industry, an industry that manufactures a product that kills over 20,000 people in the UK each year, to have a direct say in health policy and the opportunity to misinform and spread doubt among politicians and the public. The alcohol industry exists to produce and sell alcoholic drinks and make a profit in the process. It is somewhat unsurprising, therefore, that their objectives are not focused on improving public health, and that their lobbying of government and framing of information does not improve the health of the country. However, much of their lobbying activity goes much further than this, as it directly prevents or slows the implementation of evidence-based measures that would reduce deaths from alcohol. Therefore, there is clear rationale for the industry to be excluded from the development of public policy, particularly health-related policy. For more information on this topic, check out the briefings on our website.
So what's the best way for a woman over 40 to lose belly fat? This is a great way for women to lose weight, right? And this is also an amazing way to lose weight, right?
Wrong.
Hey, what's the problem?
Sorry, I mean, your workouts are the problem. They might work for you, but for women over.
Wait, I was watching that. Women
All
over
right,
40 and
colleagues.
belly fat.
Hello, colleagues. We are now back.
Hello.
We are now
Hello,
back,
colleagues.
colleagues. Let me also welcome again all members to our meeting. I'm gonna ask the deputy chairperson, Umama Dlamini, maybe to come up with the open discussions for the NDMP implementable, whether it's implementable or not. And then for a few minutes, and thereafter we chat so that we can go to the next speaker, who is the GC chairperson, Mekela, who is going to also elaborate more in terms of adoptions. Can we hand over this to a deputy chairperson of the CDA, Umam Dlamini? The podium is yours.
Thank you very much, Mfundisi. So where we are now, we are towards the end of our program for today. And we have had many deliberations, which have been quite informative and will be submitted. The last that we are on is a plenary reflection on what would make the National Drug Master Plan implementable. There are certain points that we have already made that are around communication, advocacy, having clear and measurable objectives and indicators, funding money functional coordinating structures. So basically making sure that the CDA, the PSAFs, and the LDACs are working. We need to ensure that there's coordination and integration between the plans of departments. Evidence-based programming, that is a word that kept coming up. Make sure that everything that we're doing now is scientific evidence-based. And we need to also make sure that there's monitoring and evaluation, and we have a clear framework. The National Drug Master Plan as it stands right now needs to be tightened up in terms of the M&E framework. And also the targets, the departments have to provide us with targets, but then not only the departments, because if you are saying it's now a plan for the whole country, for all of society, for all of us, then that would mean we also have to contribute to that, to say, this is what we're going to do, which is another reason why it was so important for all of us, all the sectors, to state what exactly would be their target proposed for the next NDMP. And then, of course, we are saying we need to make sure that this next NDMP has serious community and civil society involvement. We cannot have it happen as it was the previous years, where it's just government, and it's like we have a hands-off approach to the plan when it's supposed to be our plan as well. As it's supposed to be a country plan. It's not necessarily for government alone, but we need to make sure that we're part of the implementation, and we make sure that we are seeing it in our communities. With that, I would like to ask, perhaps, because those are the things that we've noted already from the discussions that we have had since yesterday, so yesterday and today. So is there anything else that we think would be important to include? And we want to note those things. So that's what we are doing now. Just noting anything else that you think we may have missed or we may not have discussed since we started talking, that would assist in ensuring that there's implementation of the National Drug Master Plan 2025 to 2030. I will be looking out for hands, and I ask that Mfundisi Sokana now please watch out for hands form as well.
Okay.
I am not seeing any.
Okay. Yeah, colleagues, do we have anything maybe that you can ask, or maybe to add, or maybe to feel that it was not discussed, so that now we can discuss it here? Remember, we don't want to left anything right now here. We are at hours where we need to decide. You need to make sure that now we go deeper, strategic deep dives and sectoral commitment. So we need to make sure that now we don't leave everything behind. Do we have any other inputs or questions, colleagues?
Going once, going twice, it is gone.
Gone.
Okay. Thank you for this. And then the second thing that we would want to know, is there any voice on the platform that feels they have not had a chance to speak?
Yeah. Interesting question, colleagues. Any voices still feel unheard? Or how can we ensure ownership of the implementations, colleagues? Yeah. One, two. I think we have covered some of the areas that we feel that now were not covered. If we are okay, colleagues, can you allow us to continue with the next speaker?
Through you, Chair.
Okay.
Yeah, DC, can I also suggest if people comes up with something that they want to write, maybe they can even send it on the group so that it can also be kept there if it comes as an afterthought. Thank you, Chair.
Okay, thank you very much, Babu Murabe. Yeah, I think that's a good suggestion. If you feel that you weren't able to speak, you can also write to us on the chat, and then you are also more than welcome. Yeah. Yeah, thank you very much, Dr. Morabe. Right, colleagues, can we go to the next speaker? We now go to the last speaker here. The next steps in the NDMP finalization process, timeline for revision and adoptions of input, a written submission deadline to a CDA. I would like to give Umamkela, the GC chairperson of the CDA, to render this item. The podium is yours, Umamkela.
Thank you very much, Program Director or Facilitator, Rev Sokana. I think it's firstly, I must say that this has been a very, very useful engagement, and very, very key and interesting and important issues came to the fore that I think are actually quite critical in terms of us really charting a way forward in a structured and informed way by all the stakeholders of the stakeholders in the National Drug Master Plan. And I think it's going to be important for us to engage further on this issue. I need to also indicate that, as indicated on the first day, that was yesterday, that the department was supposed to present us with a draft, and it was not. It did not come to the party, and therefore we do not have a draft, the initial draft that we think should be consulted with the broader stakeholders. Be that as it may, we appreciate the input that has been received, and we are going to forward that input and engage the department on the input that we have received from all of you. And more critically, I think we're going to be having a meeting that's still being planned with the department, where we are going to see the work that has been done by a service provider, because a service provider was appointed to do this work. We are going to be engaging with the service provider and the department that has been leading the process. What we have done now is to give our view as a CDA and with our stakeholders to say this is what we think should be, and this is going to inform our engagements with the service provider and with the department as well, so that the final draft is made available that would incorporate all the inputs that we have received. And once that final draft is given, I'm sure we would want to further engage, take final comments, because now it's our input, but we haven't seen the final draft document. So we would need to circulate the final draft document to all the stakeholders for their final comments. And according to the minister, he wants, even though he said yesterday that he doesn't think we are going to be ready by June, but he wants to have the National Drug Master Plan finalized by this year. So that would be the way forward. Everything is going to be incumbent upon us meeting with the department to see what draft they have and try and integrate all these documents that are on the table at the moment. Yeah, I think that is it. There's a lot of pressure. We had requested the Deputy Minister to extend the current National Drug Master Plan. So until the new one is in force, we are still using this current National Drug Master Plan, 2019 to 2020. But again, thank you very much for the input. It is going to be considered within the CDA, and we're going to engage with the department. The planned date for that meeting is the 29th. We still have to wait and see whether it will materialize, but it's there when we are going to have serious engagements around this issue. Thank you, Chair.
Thank you very much, Umamkela, for assuring us that there will be a leading process engagement towards the final draft. Thank you so much. Thank you so much, colleagues. On that note, colleagues, we go to the last speaker on the closing remark and appreciations. the CDA chairperson, or if she's now there, the CDA chairperson,
Yes.
Umayatula Khoza.
Thank you.
And then, yeah, okay, okay.
Yeah.
Okay, the podium is yours.
Yes, thank you very much, Reverend Sokana. Indeed, we've come to the end of our very successful stakeholder engagement. It's actually an extended general meeting, so we decided to extend it to everybody who has an interest on the National Drug Master Plan, but who are also implementing the programs, the strategies that are in the National Drug Master Plan. So thank you for that. Let me express gratitude on behalf of the Central Drug Authority, firstly by acknowledging the speech, the opening remarks from the Deputy Minister, Mr. Hendricks. By the way, we have received an apology that he actually is attending some parliamentary meeting, so he wasn't able to come back. But he is grateful that he was part of the opening of the meeting. So just from his input, the takeaway for us is that the Deputy Minister has indicated that substance use and illicit drug trafficking in the country should actually be declared a national disaster. So we hope that now that he himself has said it, we've said it in the past as the CDA, now that a Deputy Minister has said it, he will actually deposit this idea into Parliament, the parliamentary committees, and up to the Cabinet of the Republic of South Africa. I think as we indicated when we started, I mean, GBV, HIV had been declared, national challenges or disasters. Why not declare this particular pandemic as a national disaster as well? So secondly, he basically indicated, the Deputy Minister indicated that there's a need for focus on strengthening prevention and treatment. But we've heard from this session that let's not forget harm reduction as well. It's very, very important. He's concerned about the drugs, the entrance of drugs in schools, and that we definitely need to effectively address that. Remember, he also said that the CDA is the one that should develop the National Drug Master Plan. And I think now that the Deputy Minister has been the one that said that, he will need to ensure that indeed it ends with the CDA, the approval really ends with the CDA, then it goes straight to the Minister, and then it goes straight to the Cabinet. As a document that has been widely consulted, we think that we've widely consulted in the past 2 days, and that you have made a very rich contribution to this process. And we will revive the task team, because there is a National Drug Master Plan Review task team. We must revise it to see to it that the new National Drug Master Plan complies with what we have been discussing during the next 2 days, but to see the process through as well. Okay, and then I think the one thing that the Deputy Minister also emphasized, I think he always talks about one plan, one budget. And it has already been indicated that the current National Drug Master Plan was not costed, and therefore there was no budget. So it's very important, therefore, to ensure that there's that one National Drug Master Plan, and that there should be a way to have to cost the new one, and to have a budget to ensure that it is effectively implemented. But also to add on that, we must have a populated monitoring and evaluation framework with targets and indicators, because the one that we have now is very silent on targets. Okay, and lastly, from the Deputy Minister, he indicated that we need to ensure the implementation of the parliamentary resolutions on the CDA report. Remember, the CDA report was presented at Parliament, and then the Parliament resolved that one, the IMC should be established very, very urgently. And then there was another second resolution that is escaping my mind. Okay, but I'm sure we can refer to those resolutions. And then moving away from what we take from the Deputy Minister, we just want to say thank you also. We want to say thank you to the Deputy Minister, but we also want to say thank you to all of you. Really, the theme was about a shared responsibility. What we have observed from these engagement for the past 2 days is definitely a sense of shared responsibility. We all seem to be committed to deal with substance use disorder, as well as we must never forget illicit trafficking, because as long as there's supply of illicit substances, there'll always be demand. But also as long as there's demand, there's going to be supply. You know, it's like an egg situation. But we are grateful that all of you here have really showed commitment to address the situation. And you've showed that we are definitely going to have a collective action in terms of implementing. So we don't stop. We continue to implement the current National Drug Master Plan whilst we are developing the new one. And we do it as a collective, not as individuals, not in silos. This is what you've been saying throughout the 2 days, so that there can be lasting impact. So that's the theme. And I think that the theme got reflected in all the discussions that we were having. And then we, you know, as a CDA in particular, we had said, you know what, we want to listen to the voices. We want to listen to the sector, we want to listen to everybody, and that we speak less as the CDA. And I think we've done that. Everybody has indicated that, you know, we've participated, we've made contributions, and our voices have been heard. And I want to reassure you that we have heard each and every voice that has raised something in this meeting. And but we also had the voices from the chat groups and from the commissions as well. And we have taken notes, and we shall be able to put together a report of all the voices that we have heard today. So again, what we're taking from the discussions over the past 2 days is that there is sufficient consensus that says, indeed, the National Drug Master Plan is still relevant, but we definitely need to strengthen it here and there. And you have pointed out all areas that need to be strengthened, and we appreciate that. But you also overemphasized the importance of evidence-based information, evidence-based data, so that that can actually be able to inform correct and effective policies and legislation. We then also really want to thank you for interrogating the current National Drug Master Plan, the goals, all the 7 goals, and you've actually directed us as to what needs to be strengthened in each and every goal. And through the Mentimeter, Dr. Andrew, we thank you also for checking with everybody as to whether the vision and the mission is still relevant, or we need to tweak it here and there. And I think we are very much clear as to, you know, how this needs to be done. And thank you for really facilitating the Mentimeter. It's one tool that I like very much, because many people are able to make a contribution. So through that tool, I think I had you know, participants confirming that the goals of the National Drug Master Plan are still relevant. We just need to, you know, tweak them here and there, and be able to include also the issue of resourcing of the National Drug Master Plan, includes the issue of community engagement and aftercare. So we will find a way when we prepare our submission that those aspects that you added are actually added into the National Drug Master Plan. You also emphasized the importance of human rights. I think we went back to the principles of the National Drug Master Plan, and it looks like you are confirming that those principles are still relevant, that everything that we do should be human rights based. It should be, you know, multi-sectoral. Let's not work alone, but work together with all the sectors like we did over the past 2 years. It's 2 days. It should be evidence-based. It should be people-centered. We must include, let's not leave anyone behind. We must, all the structures, the CDA, the PSAPs, the LDEX must be inclusive of everyone who has an interest to have a role with all the new experiences so that we don't leave anyone behind. And then we also appreciated the voices from all the sectors, government departments. We were a bit disappointed that it was social development and the Gauteng education department who were part of that sectoral engagement. And we will find out as to really what happened here, but all those government departments that participated are appreciated. We also had voices of civil society. We had voices of research and academic institutions. We have voices of youth as well as people who use drugs. So thank you very much to all the sectors that actually made a contribution to these 2 days. So I think we will then ensure also that the revised National Drug Master Plan is aligned not only to the community voices, to the voices of sectors, but that it is also aligned to our national medium-term development plan that the DC presented. It's also aligned to the 2030 National Drug Master Plan. It's aligned to the SDGs because there are those goals that talk to, health and well-being of people, including, public health for those who use drugs, and that it's aligned to the African Union Plan of Action as well. So we will ensure that we take into consideration those areas of the National Drug Master Plan. But I think one other thing that we did not do well is the management of risks. We need to ensure that going forward, we will have a risk register with the National Drug Master Plan in as far as we will have the M&E framework that's populated. So in conclusion, really, let us thank all of you. In particular, let us thank the team behind, there would be a team behind curtains who make things happen. And I really want to express our appreciation for the success of this session. Of the board of the CDA, the CDA board as a whole, but of course the board is led by the executive committee members, and the executive committee has various committees, and there's this one committee that was really behind the plans and the facilitation of the session, that is the communications and marketing committee, and we thank those colleagues very, very much. They've worked very hard, but in particular the deputy chairperson, who really, I should indicate that she really works as if she's the executive director that we need in the CDA, so we really appreciate all the work that you have put into this session that was very, very successful. Of course, you don't work alone, you work with all of us. We thank the secretariat that was present. I did see some members of the CDA secretariat and admin that really were very, very supportive and taking notes and reporting back. The facilitators, the main facilitators, all of you colleagues, we are members of the CDA, but you are also external members, the note takers, the rapporteurs. We thank you very, very much. The collective effort made this session really very, very successful. And as it has already been said, you will receive the presentations. I think the DC will advise as to whether the presentations can be uploaded on the website of the CDA, or we can find another way because people were asking for the presentations. We will also ensure that the Secretariat assists the CDA in putting together a full report of this particular session, the stakeholder engagement, so that, as Memkela was indicating, we can make a submission, to as the CDA with our role players and stakeholders to the National Drug Master Plan process. So yes, as I've indicated earlier, it's our wish that the new National Drug Master Plan is really launched by June, if not possible, at least let's say by end of the year. It really, really must be launched. And remember that in November we are going to have the 4th biennial summit. Really to consolidate all the work that we have done over the past 4.5 years, or it will be close to 5 years, right? So to consolidate all the work that we would have done, find a way to prepare a 5-year report so that we can then hand it over to the new members of the CDA who shall be appointed by end of March next year. So thank you very much also for using your data for 2 days. We really appreciate that. And rest assured that we as members of the CDA also use our own data, for all our meetings. So we thank you also for doing the same. And so with these few words, I'd like to therefore declare our stakeholder session officially closed, and please leave no one behind. Thank you very much and enjoy your afternoon.
Thank you very much, Chairperson.
Thank you very much, Chair.
Everyone.
Thank you.
Bye.
Thank you.
Bye.
Have a good afternoon. Bye.
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 Thank you. Bye.
Thank you, Chair.
Thank you, Chair. Thank you, everybody. Have a good day.
Thanks, everyone. Goodbye.
Thank you, Chair. Bye.
Thank you, colleagues and everybody.
Thank you, everyone. Bye.
Thank you for 2 days of a great session. Thank you so much. Highly appreciate
you.
it.
Thanks. Bye. Bye.
Thank-
Thank you, Chair. Thank you, Chair, and everyone.
Thank you very much.
Thanks so much.
Long live Gauteng and Eguruleni.
Long live. Thank you.
Thank you so much, Bob Gamma, for this.
Thank you. Thank you, Maholo. Thanks.
Thank you, Chair.
Yes. Okay. I'm waiting for the last person to leave.
All right, Mama Tulokoza.
Ebulela, thank you so much.
Bye-bye.
Thank you so much.
Okay.
Okay, cool.
Cool. Right. I'm leaving now.